So let me first of all start with wishing you all a happy new year. Not too late, I suppose. So happy new year to everybody and welcome. So we're going to have the SAARC Federation of Oncology meeting, and this is the 15th SFO conference. And I see most of the people who have been actively involved in SFO already logged in. So welcome you all, and I'm sure people will slowly join in. So again, you must have got this flyer. So I must thank Amit for all the work that he has put in to make this successful. I must start on a solemn note that we lost Dr. Shanta on 19 January. I'm sure all of you know Dr. Shanta. She's one of the pioneers in oncology in India. And she actually worked towards what the SFO is looking at to make cancer care affordable for everybody in this region. And so I just want to say that, just to quote, that when a sick approach the gates of the institute, weak in body, mind, and spirit, and full of fear, there is only one response from you, that you have to become a part of them. I think that underscores the statement as to how you should treat these needy people. And we have plenty of them in our region. So I thought I should share this with you. And unfortunately, we lost her. So it's a solemn moment for all of us. I'm sure you've got the whole agenda, and we have a busy 2-day schedule. And I'm sure at the end of it, all of you will be wiser, and we will share our experiences and see how we can carry forward the collaboration. Unfortunately, because of this pandemic, we were not able to do a lot of face-to-face meeting, but we did some virtual meetings, and this also is ending in a virtual meeting. So hopefully soon we will see each other face to face. So with that, I think I will thank you all once more, and hopefully we'll have a very fruitful and useful meeting for all of us. Thank you. Over to you, Kashish.
Thank you so much, sir. Sir, it's currently 4:52. Should we wait for 5 p.m. for the next session, sir?
No problem.
Yeah.
I thought I'll save time, that's all.
Sure, sir. So we're just waiting for 3 panelists for the 5 p.m. session. They'll just be joining in another 5 minutes.
Sure.
In the meantime, we can discuss something about. Excellent. Thank you very much, Govind. Thank you very much, Dr. Bhatt. It's a pleasure to be part of this very important SAARC Federation of Oncology. It's nice to see all of you virtually. For the first session, we have none other than Professor AFM Kamaluddin from Bangladesh. He is a founder member of SAARC Federation of Oncology. Oncology Club has always been at the forefront with innovation, and we are looking forward to a wonderful discussion of a very relevant topic for us here for the South Asian countries. So without wasting much time, over to you, Kamal.
Thank you, Purvish, for the nice introduction. I am really grateful to the leadership of current SAARC, and we are privileged to start with starting session, kickoff session from joint session with Oncology Club. So today, let me go to the topics: challenges in transition to patient-centric EBM of lung cancer. So this is the point of discussions. We know that we had the transition from experience-based medicine to evidence-based medicine, from evidence-based medicine, then we have shifted to patient-centric evidence-based medicine. But unfortunately, even in NEGM, BMJ in 2008, it was said that 21st century clinician who cannot critically read a study is unprepared as one who cannot take a blood pressure or examine the cardiovascular system. But still in our region, we are struggling to execute the evidence-based medicine. And that's why this session was designed. So I have a good number of panelists: Dr. Rajeev from Nepal, Dr. Purvish Parikh from Mumbai. I have 3 panelists from Bangladesh: Dr. Shahida Alam, Mustafa Aziz, and a student, Altaf Hussain Riyad. We have Manoj Mahajan and Dr. Mangesh Kamar, both are Udaipur and Bangalore. So straight away, I start with ladies first. Let me start with Dr. Shahida. And Shahida, you are there, I'm sure. So I know you are working in.
Ma'am, you'll have to unmute your mic, ma'am.
Sorry?
For Dr. Shahida, you'll have to unmute your mic.
Yeah.
So Dr. Shahida, you are working the Cancer Institute, and I know it is the largest government institute of Bangladesh. So may I request you to give the idea that what the bullet point challenges that you think, the top 2-3 challenges that you think is the barrier for shifting to executing EBM in lung cancer, patient-centric EBM.
Okay, good evening. And first of all, my gratitude to the organizer for this opportunity to be here. So as I'm working in the National Cancer Institute, so I have to treat, and I love to treat the common people. And I feel that the consensus to clinic, this distance is quite huge in the government sector of a developing country. And that is not a surprise because all the evidences come from completely different healthcare system. So to practice the evidence-based, patient-centered evidence-based medicine, probably the most important thing is to stratify the patient according to the histology and the available investigation, the imaging, who are potentially curable, who are curable, and who are incurable. So I think our struggle starts from there. Still, we have more than 80% of patients referred with cytology, not a core biopsy. And from our government hospital, we can't provide all the necessary investigations and imaging facilities to the patient to properly stage the patient. And even we can't refer the patient outside because most of them can't afford. So the resource limitation for a proper staging of the patient is the first challenge for me. And I'm a bit mortified to say that the second challenge is the doctor's mindset. So instead of this recent advancement in the lung cancer management, still the doctors have a different thought process, like how much you do for the lung cancer patient, you can't have a great outcome. So we have that type of mindset. So you know, I'm a radiation oncologist, so we have our radiation facilities are quite limited in the government sector. So in our department, there's a huge queue for radiation. So when, as a radiation oncologist, when I think of the best and rational use of my limited resources, like the linear accelerator, the 3D CRT, concurrent chemoradiation, the radical dose, fastest queue, we always think of the breast, cervix, head, neck, rectum patients. So for lung patients, we always think the cobalt machines, the 2D simulation, the palliative dose, the sequential chemotherapy rather than the concurrent chemotherapy, and the long queues. So this is the second thing. And from my experience, and the third challenge, I think, now we are getting more and more elderly patients, 65 plus. So obviously they are not working. They don't have any insurance support. And from our government side, we don't have any senior citizen support system. So especially in the low socioeconomic condition, the reality is that the support from the family is not that great. And that drops down in the course of treatment even. This support is not only financial. Who will take the patient day after day to the hospital? This is also an issue. So for this and many other issues, lung cancer being the topmost malignancy of my hospital years after years, it has never been our top priority in the treatment protocol.
Thank you, Shahida. We get I think almost a common insight in all the SAARC countries, more or less in the government setup. So to supplement it, I would like to request Dr. Mustafa Aziz Shumon. He have the exposure of working in a corporate hospital in the same country in Bangladesh. Mustafa, would you like to add 1 or 2 points? What do you think from the private setup in our country?
So thank you, Dr. AFM Kamaluddin. So at first, I partly admit with Dr. Shahida Alam because resource limitation is there definitely. But beside this, I have seen a number of patients with T1, 2.8 centimeter size, having R0 resection. Patient is advised for chemotherapy, radiotherapy. So I should want to include that there is a limitation in knowledge and definitely the attitude. We have a attitude that a cancer patient should be treated with a combo, surgery, radiotherapy, chemotherapy. So there should not be a patient stratification is there. And beside this knowledge and attitude, we have skilled manpower limitations because if you want to do a core biopsy, I know we find challenges. We don't have genetic mutation test over there. We don't have what we could say the liquid biopsy facilities. So in added to the research limitation, I would like to highlight the knowledge and attitude and skilled manpower limitation in our country. Thank you.
Thank you, Shimon. So that is a new insight I get. So now the last from Bangladesh is a student. We have selected Dr. Altaf Hussain Riyad as a student, PG student. What do you think? One point you want to focus that you think could be the barrier in your eye for practicing patient-centered EBM in our country, in lung cancer.
Thank you, sir. Altaf. Am I audible?
Yes, you are audible. Please quickly finish it. Yes, Altaf. Hello. Altaf. So sir, if he's not, yeah, are you there?
Sir, I believe his screen is frozen, sir.
So he have some issues. So we move to Nepal because we don't have much time in hand. Dr. Dewin from Nepal. So may I have some comments from you, from Nepal's perspective? What do you think that the challenge to move from current practice to patient-centered EBM in lung cancer in your country? I have no idea how far you are practicing in your country and what is the challenge that you think.
So, Dr. Rajeev, you'll have to unmute your mic,
Dr. Rajeev from Nepal. Rajeev Dev.
Sorry, sir. I was disconnected. Am I audible?
Yeah, please. You have only 2 minutes time.
Okay. Thank you, sir. I think the lack of evidence-based practice in real life makes us
so you will
I think we move to Nepal. Dr. Rajeev from Nepal, are you there?
Rajeev, unmute yourself, please.
Can you please unmute and give the comments?
So Dr. Rajeev, you've been unmuted. So can you remove your headphones, sir? I believe there is some audio issues at your end, sir. Yeah, so now we can hear you, sir. Now we can hear you, sir. Now we can hear you.
Yeah, thank you. So thank you, Dr. Kamaluddin. I'm practicing in a government institute in a military. And as a doctor from Bangladesh said, the issue is the resource limitation because all the tests that we want to do for evidence medicine cannot be done most of the times. And the priority is to get some kind of a treatment anyhow. So instead of going for evidence medicine in the beginning, so what we practice is try to get some kind of a treatment first, and then once they are in the treatment, then we can properly discuss more about evidence-based medicine and what are the next practices. And then even though we discuss all the options, the priority would be it won't be affordable to most of the patient, and the resource available is also an issue. So it's a good thing that we need to understand what is the latest evidence in men with lung cancer. But the practice is, I think it's going to take some time, but I think we have some kind of started doing most of the things, at least discuss about all these issues and then go forward accordingly.
Thank you, Dr. Rajeev. So now from Nepal, we move to India. May I request Dr. Manoj Mahajan from Udaipur. I'm sure Dr. Manoj can give us a bit different scenario. Dr. Manoj, few words from you. What challenge that you think from us?
Am I audible?
Yeah, you are.
Yeah. Sir, few are the common things are still there, like financial issues and government schemes. There are certain government schemes are here where we can treat based on few of the evidence-based practices. One thing I would like to emphasize on the view of this meeting is like implementation of EBM in terms of patient-centric awareness, because many of the times, even if we are able to implement all the recommended guidelines, lack of awareness and there is absolutely minimum awareness about the symptoms plus if I talk about the rural area of Rajasthan, there are many of the patients don't come and they hesitate for taking the treatment. Even if the resources are available, finances are not an issue. So that awareness part, implementation of EBM is one big resource, and making them aware that this is the treatment and you have to take it and this will cure you or control your disease to a certain extent. This is also one important aspect we need to work on. Once you have the resources, the awareness of disease and correct treatment. Many of the times patients go away for like alternative therapies and they come with a very advanced diseases, then it becomes difficult. Even if the finances and resources are not enough to. So I think that point we need to take beyond the availability of the resources to the implementation of the resources.
Thank you, Manoj, bringing a very important, relevant, but a bit different type of challenges that we all face, because this is a common picture in all our regional countries, that alternative medicine and many Dr. Google Babas are there who become a barrier in the process of our treatment. So now I want to come to Dr. Mangesh Kamal from Bangalore. Dr. Mangesh?
Sir, Dr. Mangesh has not joined, sir.
Okay. So as per our plan, I want to go back to all the speaker. One point that you think that how can we overcome it? I start with Shahida. One point that you think that is very important to overcome it.
So first and foremost, we have the capacity building in the government sector in terms of infrastructure, technical support, and the manpower. And I think we should concentrate in site-specific practice so we can keep ourselves updated more and more. And we have to provide a senior citizen support system from the government.
Thank you, Shahida. In our country, still we are not doing site-specific practice, which is a big challenge for us to become updated and focused. And yes, senior citizens also issue. Country like us not giving a due importance to that. So thanks, Shahida. Now move to Mustafa. What is your comment? One small important point that you think that could be the key to solve this issue?
I think a regional adoption of guidelines can be a issue, can be a solution, because though the ESMO has a pan-Asian adoption, but still we have some geographical socio-economic diversity. So I think a regional adapted guidelines can be a solution. Thank you.
Thank you, Shuman. Very important point. We discussed many times in SFO platform of they're having a regional guideline, and also I think it should be not regional, also resource stratified guideline, because in region we have different level of resources. So that is a wonderful suggestion, I will think. So Altaf, are you there?
Yes, sir. Am I audible?
Yeah, please, very quick. This is the third and last chance for you.
Okay, sir. In my opinion, I think the lack of evidence-based medicine in our practice makes us flexible and discouraged to consider this issue during our study. And again, this lacks, and for this lackness, we can't face any challenge. So I think this is the main issue.
Okay, Riyad, I understand. As there is no much practice of evidence-based medicine in the real life, so as a student, you don't feel like focusing on this much, because you know that yes, maybe you will not be challenged like that. Thank you, Altaf. Coming back to Dr. Manoj again, so wonderful insight that you gave. So overall, what do you think that in our country, a regional perspective, how can we overcome these challenges of not having adequate evidence-based medicine in our region? Dr. Manoj.
Sir, one more thing again, I'll talk about the implementation, because what I feel, I'll just give an example. Whenever a chest pain happens, clinicians at the grassroots level do ECG. So probably that is the success of the cardiologist united efforts. So from implementation, I agree with other colleagues also, because there are certain resource limitations. But implementation part also we need to look into, or especially we need to make other clinicians who are most of the time they refer to the patient. They should be a part of process of implementation of EBM. So making physicians, gynecologists, clinicians aware about the oncological practices, right? Correct practices. That should be our next level agenda to make them aware. so that they will also brief the patient about the correct things.
Thank you, Manoj. It is very
Dr. Kamal,
important.
can
Yes,
I
I know. I am going to invite you, Mr. President. So so Manoj, thanks for the insight. So now we have the representative from Pakistan, a good friend, Dr. Izaz Masood, who is the incoming president of SFO. So why not to take the opportunity to hear from him, Dr. Izaz Masood? Assalamu alaikum. Some comments from you.
Thank you very much, Dr. Kamal, and everybody. My comment is that there is a big problem that we don't teach oncology at undergraduate level. And people don't have any knowledge of oncology till they adapt this specialty. So we have to educate the undergrad students before doing their medicine completed, so that they may know what are the basic things of oncology. That is the problem in my country. I don't know about the other countries, how much oncology is being taught in your countries. But as far as my country is concerned, that we have problem. Most of the lung cancer patients, they are given ATT. And for 3 months, they take ATT and then they go for diagnosis of lung cancer. Similarly with other cases. And secondly, the concept is that most of the patients, they say once a cancer is there, the patient is dead. No one is going to treat it. So we have to take courage and take steps to teach 3 Ps. Number 1, the patient. We have to educate the patient for early diagnosis. Secondly, we have to teach the public who are with the patient so that they get early diagnosis. And thirdly, we have to teach the physicians so that they can refer the patient at proper time to the concerned doctors. So we should do at undergrad level and also to the postgraduate level. We should teach the people that what is oncology, whether it is radiation, whether it is surgical, whether it is medical. We have to tell them that this disease is not that disease which is uncurable. This is a curable disease. As we detect it early, we will get the best test results. Similarly, as you are saying, as Mustafa said, that we should have proper regional guidelines. And I think this we decided when we were in Sri Lanka, that we should have proper regional guidelines. And that is the thing, we don't go for it. Even with chemotherapy, our region where average hemoglobin is around 10, and in Europe and America where average hemoglobin is around 16, 15. So when you do chemotherapy, the effects are more in our people. So we should have our own guidelines. We should modify the doses of the chemotherapy and similarly other things. So this is my recommendation for you people. Thank you very much.
Thank you, Dr. Izaz. Good to see you. And it is a pleasure to get Pakistan comments and also from incoming Mr. President's comment.
Thank you very much.
As per our plan, when we decided this panel, the person who volunteered to be a panelist is Dr. Purvish Parikh, who appreciated the idea of having this discussion. And he is not only a renowned medical oncologist, but he is a lung guy. And he is not only an oncologist, he is dealing with many current challenges and how to overcome these things. So why not invite Dr. Purvish to make a comment on all the comments and also give a way out as a SAARC region. Purvish.
Thank you very much, Kamal. It's always a pleasure to interact with you and all our colleagues. Many of the challenges have already been expressed by the panelists. But I think what I would like to focus on is 2 words, and that is unrealistic expectations. Every stakeholder in oncology, and particularly in lung cancer, seems to have an unrealistic expectation. If we start from the patient party point of view, they are not interested in giving up smoking. They are not interested in giving up tobacco. They are not interested in doing screening or coming to the doctor when they have early symptoms. So that is an unrealistic expectation. So also at the other extreme, all of us oncologists want to take the responsibility of everything on our head. Our primary objective should be to treat the patient in front of us. whether the government provides us infrastructure or not, whether there is enough manpower or not, there are senior academicians and administrations who are responsible for that. We should focus on providing the best treatment under our circumstances to the patient who is sitting in front of us. If we have to, divert our attention to providing accommodation or transport for an elderly patient to come to the hospital, that means we are taking time off from treating a patient which nobody else can do. So I think that is what we need to focus on. Also, when the diagnosis is made, I'm sure that 90% of lung cancer patients cannot be cured. So there also we have to be clear as to what is our goal in this particular patient. In 90% of patients, we will be giving palliative treatment. In 75% of patients, even today, we don't have a targetable, druggable mutation. So we will have to go to standard treatment. And in a lung cancer in the palliative setting, whether we do SBRT or 3D CRT or cobalt, I don't think it makes a difference. So evidence-based medicine exists. If I have a patient who has all the resources, or if I'm in a private setup which has all the infrastructure, of course I will give the best treatment. But that does not mean that a patient who is not poor, who is not having resources, or an institute or a center which doesn't have the fancy equipment cannot treat lung cancer. We have to treat our patients in the best possible way. And ultimately, the incremental benefit is only 5, 7, 10% if you look at the best class of treatment. If we only focus on technology, if we only focus on recent advances, 65% of cost of oncology care today is because of technology. And how many, even in United States, if immuno-oncology drugs are used in all patients with lung cancer, the country will go bankrupt. What about the poorer nations or less developed countries in South of Asia? So we have to take all of this, and I think it can be summarized in unrealistic expectations from all parties involved in the involvement of lung cancer. Over to you, Kamal.
Kamal sir, please note, 5 minutes left, sir.
Yeah, thank you, Purvish. I was quite scared because you are very tough on time. So we have 5 minutes time. So if I summarize that all the points has come up, that resource limitation, knowledge, attitude, mindset, and also the barrier, stratification issues, and also the lack of our regional guidelines. But I think what Purvish has said, we need to do whatever we have. We cannot solve everything. We need to understand our limitation. We cannot cure every patient. We cannot solve every problem, but we need to solve what is possible. So that there is no big change, but still in stage 4 now, we have a survival of 35 to 40%, which is a reality. Say now we are having generic drugs, which is affordable. We can give it to the people. And SBRT is an issue of only 5% patients. So that is not an issue. So what I think from the discussion, it came out that we are having almost a similar picture in the whole region, that poverty and lack of resource is a big issue. But in addition, we are not always really tuned, neither the patient, not the doctors, and also the treating physician. Doctors mean I'm the referral physician. So I think Dr. Izzaz Masud raised a very important thing, that we need to have a proper referral rather than treating the patient as a tuberculosis. We should have the patient on time so that we can treat the patient on time. And what Dr. Purvish said, we should know when to stop, because in our region, there is emotional challenge that we face from the patient's party, that do something. So we are not the Khaja Baba that we are going to cure it, do something. Sometimes we need to stop and say, hey, we cannot do everything. So lung cancer is still a challenge for the whole world. So it is a challenge for our region. I think our existing, there is a guideline from Tata, which can use, and a National Cancer Grid has started developing some guideline in India, which is research stratified guideline. I think we can use this. And again, we can bring the discussion of having a SFO-based guideline, which once we started under the leadership of Dr. Kumar Provas with the guidance of Dr. Purvish, we can restart that and have one thing. So I think it was a wonderful opportunity for me to have everybody of us. Thanks to all my panelists. And finally, thanks to the organizer to give me the opportunity to moderate the session. Thank you. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you so much, sir. We'll now move on to the next session. This is the academic session number 2. This is a joint SFO-NSFO session. The topic is biomarker testing for precision oncology, SAARC perspective. Our moderator is none other than Dr. Rajendra Baral, radiation oncologist from Nepal. His panelists are Dr. Bishnu Datta Paudal, medical oncologist from Nepal, Dr. Ambuj Karn, radiation oncologist from Nepal, Dr. Syed Mohammad Akram Hussain, clinical oncologist from Bangladesh, and Dr. Sumant Gupta, medical oncologist from New Delhi. Baral sir, please note, Dr. Bharat and Dr. Guru have not joined. Over to you, sir. Yeah. Dr. Baral, your mic is not muted, sir. Oh, sorry, it's not unmuted. Sir, can you unmute your mic, sir?
Rajendra, you have to unmute your mic. We can't hear you. Baral. Unmute your mic, please.
Dr. Baral, you'll have to unmute your mic, sir.
Rajendra, unmute your mic. We can't hear you.
Hello.
Now we can hear you.
Very first of all, thank you very much to Dr. K. Govind Babu, our SFO president, and Dr. Amit Bhatt, our general secretary of SFO, and scientific chair Dr. Purvish Parikh, for giving me this wonderful opportunity to moderate this session. And the topic given to me by Dr. Parikh is biomarker testing, especially focusing in precision medicine and especially for targeting for SAARC perspectives. So, my slide are not. Can I go to first slide?
The slides are shared on your screen, sir. Can I request if you can use the arrow keys? Or you can use the mouse if that's sick. You can use the left mouse. Just click on it, sir. Yes, sir. Dr. Baral, are you able to hear me?
I'm hearing, and my slide is just a second here. Prasad?
Yeah, sure, sir.
So you are starting with the take-home message.
No. This is last. Don't worry.
Sir, if you're having difficulties, you can use the right arrow key, sir, on your bottom right-hand side. So on your keyboard.
That I'm doing.
Okay. Yeah. Okay. Yes.
So, as mentioned by Dr. Kassis, my panelists are my dear friend, who is very renowned oncologist from Bangladesh, Syed Mohammad Akram Hussain, Bishnu Datta Paudel from Nepal, a very renowned medical oncologist from Nepal. Bharat should be joining very shortly. He has ranked me. And Sumant Gupta, renowned medical oncologist from India. Ambuj Karn, our secretary of SFON, as well as very renowned oncologist from Nepal, and Guru. He's just supposed to join. He's on the way. Guru Saran Shah from Nepal. So let me start with some basic knowledge of biomarkers. In simple way, what are biomarkers and the role of biomarkers in precision oncology? Let me start from my panelist, Syed. Can you start from you, Syed?
Thank you so much for inviting me, Baral, and particularly my mentor, Professor Purvish and Parikh, and the organizers. Thank you for inviting me, and as a representative secretary also. So just for the biomarker, we know the very simple way, if you would want to say in a very simple way, biomarker is a biological molecule which we can get in blood, we can get in tissue, we can in body fluids. And in that time, what we see is a sign or marker for a physiological or pathological process. And also at the same time, we can find that actually we can see the therapeutic responses by this marker as well. Thank you.
Are you practicing biomarkers in your practice?
Yes, in general. In general, actually, we all practice with biomarker. You have said, or you have shown some biomarker. Oh, maybe I saw your slide actually shows some biomarkers. You saw the PSA, you saw C125, CA, C15-3, EGFR, HER2, C2, 27, 20, so many things that you have seen. So besides that, actually, there are other markers as well as actually, so EGFR, so there is even particularly in the lung cancer, we are doing, particularly me, in my practice, I'm basically using biomarkers available in our country, particularly for the lung cancer, colon cancer, and even other cancer, which one is available. Even including, I try to do some cases CTC, but the problem is actually most of them are biomarker is not available in our country. I need to send, I need to send it actually to India, and basically which is possible, and we have able to send to India, and the report also will come to 10 to 15 days. In general, we get the report.
Yeah, I'm seeing in this meeting, there are lots of our PG residents and registrars. They are very upcoming oncologists. So they should know what are the biomarkers and what is the precision oncology. So Sumant, are you there? Can you summarize what is the basically what does biomarkers means and how we practice in precision oncology? Sumant,
good evening, sir. Pleasure talking to you, and thank you everyone for having me on this forum. So, sir, basically precision oncology is nothing but targeting the correct molecule. See, if we have for the postgraduate especially, I like to start that oncology has been evolving. Initially, we used to have cytology, where whether the patient has malignant cells or not. Then came the role of histopathology, that whether, for example, in a lung cancer, we have a small cell, a non-small cell lung cancer, or an adenocarcinoma, squamous cell carcinoma, and we used to decide our therapy. Similarly, if we take the example of lung cancer, per se, we had these biomarkers, like Sir said in his previous just now, that we have a mutation like the EGFR mutation or the ALK or the ROS. So basis of these biomarkers, we have been able to conduct precision oncology or precise treatments. So we can decide on drugs or which are less toxic and more accurate for the treatment. So if we come to a basic thing where we are just talking on a very basic platform where for our postgraduate students, especially or for the MD students, we can say that for the biomarker helps us in finding out a drug which will be very specific for the disease conditions. So in the lung cancer, if we have a EGFR mutation, so we can choose a patient of a lung cancer to give erlotinib, geftinib, or osimertinib. Similarly, in a breast cancer case, if the patient has a HER2 mutation, so we can target these patients with drug like trastuzumab. So
agreed, very agreed, Sumant. So what is the scenario in Nepal, Dr. Ambuz and Dr. Vishnu, please, from Nepal point of view? Dr. Vishnu, Dr. Ambuz.
Yeah, thank you, Dr. Baral. As said previously also, the biomarkers is very important in the new era of the cancer treatment to precisely treat it. Previously, chemotherapy, we were using chemotherapy. Now with the introduction of biomarkers, like I started from CML with the Philadelphia chromosome positive, now imatinib has helped to precisely treat the CML. Then later on in the solid tumor, when the HER2 positive biomarkers came, then we can precisely give the Herceptin and treat the breast cancer. So like this, from Philadelphia chromosome to Herceptin to the EGFR mutation, slowly in Nepal also in clinical practice, the oncologists are using more and more biomarkers which are available, and sometimes they send outside also. Still in Nepal, we couldn't use as guideline says to each and every patient because of the financial resources, because of the limited resources due to different reasons, but still the biomarkers use has been progress, and the more and more patients are treated in Nepal also precisely with the help of biomarkers.
Yeah, Dr. Ambus, what is your view regarding these basic questions?
Okay, thank you, Dr. Baral. It's a great opportunity to be here. I would just like to differentiate two words together, not together, actually, biomarkers and precision oncology. So, as you all know that we are using biomarkers from the very beginning. If you talk only about the precision medicine, yes, for the precision medicine, we are not using lots of biomarkers, except for some to find out what are the targetable lesions, targeted mutations to treat, like in the lung cancer. But actually, we are using these biomarkers from the very beginning. It's not only for the precision medicine, also like for the screening, like other things. We can use the biomarkers for the screening, for the diagnosis, for classification, prognosis, prediction, and above all, therapy-related risk management and therapy monitoring. So, well, we are short of those of things. So definitely, if you review the guidelines, Western guidelines, there are a lot of things to be offered. But in our practice, actually, we are not using a lot of things. Suppose if someone has positive for the epidermal growth factor receptors, then definitely we have the first, second, and third line TKIs. But if someone is positive for the like EMA alpha, so at many occasions, we know that these are the targetable mutation or where you can target for the patient medicines. But to be honest, we are not using a lot of these drugs because one thing is that availability is cost. If someone has to go for the serotonin or electroneib, that is very, very expensive in our part of the world. Okay. So my question is there that if you cannot use these drugs, if suppose someone has got the adenocarcinoma of the lung, stage 4 disease, and he or she is not affordable, cannot afford something like that, serotonin or electroneib. So what is the use of doing those biomarkers if the patient cannot afford? So many times these things come in our mind. Over to you, Dr. Baral.
Agreed, Dr. Ambus. This answer we are going to answer in the last question. So, looking for the common scenario for those our students, just to brief that biomarkers and precision oncology are complementary to each other. Initially, the treatment was based on pathologic examination. Now, these biomarkers can be used to understand the pathobiology of the disease, for diagnosis, disease monitoring, and to specifically to target for the drugs. And there are different types of biomarkers, maybe genomics or maybe proteomics or metabolomics. And this is what the biomarkers is in medicine. Not only in our oncology, in different field also this biomarker testing is being done, but huge amount, around 38% is used in hematology and oncology, just for our students. And I don't want to go in depth of this. Now, coming to another issue, why should we do biomarker testing in precision oncology? Dr. Vishnu, let me start from you. Is it mandatory? Is it mandatory?
Yeah. As we talked just before, I told myself also, and Dr. Ambus also highlighted, if you are going to treat it specifically, like just taking an example, if there is a patient of adenocarcinoma, metastatic adenocarcinoma, then if there is a EGFR facilities available and you can do it, then it will help, because oral TKIs will help patient can go to the home. In the long run, it will be economical also, it will be compliance also. So that way it helps. Like I said before also, like a Philadelphia chromosome, like a CML, now we have a program, Novartis program, that it's a freely available imatinib also. So to hit specifically, now as we all know that chemotherapy hits the cancer cell as well as the normal cells. And there are a lot of complications. So to minimize the complication and increase the effectiveness, of course, precision medicine is very much important. So as Dr. Ambus said nicely, if after doing, like if you do the Philadelphia chromosome and imatinib is not available, it's no point of doing Philadelphia chromosome. So same thing. If a poor lady comes with the breast cancer and she even cannot afford for the CMF, then just doing HER2 may not be helpful. So if it is affordable and there is a solution after doing the biological markers that something is available which can be given, then of course we have to do the biological markers and give the specific precise medicine so that patient will have a less side effect and more effect. Thank you.
Exactly. Dr. Syed, can I come back to you? What is your view? So for all lung cancer patients, are you doing EGFR, ALK, or any other tests?
In generally, my personal practice, what I can say, yes, I try to do.
Yeah.
My practice, my personal practice, in generally, I do the lung cancer, all lung cancer, yeah, I'm doing that. But regarding, because you know, my last speaker also said about the diagnostic, even the therapeutic purpose, we can use it, even the monitoring of the disease. We can, even biomarker has a role of the screening purpose as well. So I do that actually. It is very, very useful for my practice. I am very much, my patients are really, my personal practice, my patients are really benefited. I found particularly for the lung cancer, you say, even the colon cancer, you say that even the breast cancer, the patients are really, really benefited from this biomarker study, and they can, many of them can able to get the appropriate targeted therapy, but some may not. You know, the Bangladesh having many drug target therapies available in our country, so we can able to use that one.
Sumant, I come back to you. I know in India, many higher centers are practicing all levels of biomarkers for better outcome and good quality of treatment. But in some places in India also, there may be some problem regarding all the tests and how you are facing a problem for this biomarker testing for poor patients.
So I totally agree with whatever everyone has said. So we have to balance this. So this has to be a very judicious balance. So we cannot have a patient who doesn't have a single penny and we write 10 biomarkers. So it has to be a very judicious call. So biomarkers have both the prognostic value as well as the treatment value. So we have to first see to it that whether the patient will benefit from a test, which will definitely have some impact on the finances as well. So if I write a panel of tests, say for a lung cancer, if I write EGFR, ALK, ROS, MET, and PD-L1, if the patient I know will not be able to take a drug which will come out of the test, then there is no point of taking the test. So first and foremost, it is a part of our clinical judgment that the tests are only written to the patients who will be having the finances or will be having a benefit from this test. Second, I disagree. For certain diseases, especially, the biomarkers are very essential. For example, if we see CML, the Gleevec, simple Gleevec has changed the total lifespan of a CML patient. From a disease which would have killed the patient in 6 months, now the patient is going to live for a normal life. 90% of patients are going to live a normal life. Second, in patients who were earlier diagnosed as leiomyosarcomas, now the simple test of GIST, most of them after doing a simple test of IHC markers, they have been transformed into GIST. So not all testing is useless. So we have to be very judicious in our biomarker testing. For lung cancer also, a single EGFR mutation might help you to give a simple tablet of geftinib, which might be cheaper than giving a chemotherapy of etoposide cisplatin also. So what I'll say to everyone is, let us be judicious. Let us talk to our patient. Let us analyze the financial condition of our test.
Selection is very important, Sumant.
Yes, correct selection.
Patient selection is very important. Yes, all patients cannot be put in one category.
Yes, I cannot write a 10 NGS for every patient. I have to understand what patient has to get what test.
Agreed. Very agreed. So I think the giving of testing of biomarker testing is for improved clinical outcomes.
Yes, sir.
So we want to have better outcomes so that we are practicing these testings. Otherwise, no way out. So this was the pre-biomarkers era, traditionally chemotherapy, now coming to the biomarker testing for better outcome. And as you all have mentioned that in lung cancer, see KRAS or ALK or EGFR, PD-L1 for immunotherapy. Now, if you are not able to, as mentioned by Dr. Ambuz, if you are not able to give crizotinib for ALK positive, then why do you need to do ALK? Do you mean to say that? But if the patient can afford, and we should give option, if they can afford, I think we should provide the test. Now in Nepal, we are practicing EGFR, ALK, KRAS, and for PDL1 also, where our practice is coming up. So let me ask Dr. Masood, you are from Pakistan, although you are not in the panel. What is the scenario of practicing biomarkers in Pakistan? Masood? Hello, Masood? You are there?
Okay, so you'll have to unmute your mic.
Thank you very much. I'm very much here online. The practice is almost the same as what in other SAARC countries are, that we do have, but the same thing which Dr. Vijayakumar said, that unless and until the patient affords and we can give those medicines to these patients, only then these biomarkers should be done. Otherwise, it's useless, it's the waste of money. Similarly, we do have to go for all these tests, and we should check our own scenario, because all these setups, as I said in the previous meeting, that we should give our own recommendations, so that we must say that how much biomarkers our setup is going to benefit. What patients from our setup going to benefit out of these biomarkers? Let's study that also. We have to search it out, that whether these markers are beneficial in our population. Conventional chemotherapy, can that treat these patients? Because the most important thing in our setup is poverty. That the patients in our setup are very poor.
I agree with you fully. I agree with you. Again, coming back, in India, most of the centers, higher centers are practicing most of the biomarkers. So we are talking about SAARC countries. What is the common biomarkers you are practicing in Pakistan, or I mean Bangladesh, or Sri Lanka, or Nepal? That is the issue. So
the issue is
above.
The thing is that most of the patients, they are not getting biomarkers done. Okay. And most of the patients, we do get this HER2 new or these KRAS.
This all gefitinib or erlotinib for lung cancer patient?
We do think in certain patients, those patients who afford it. But most of the patients, they are non-affording.
Then how do you give? Empirically you are giving, or with test?
With test. Whomsoever we give with test, not without test. We don't give empirically.
Syed, common biomarker in Bangladesh.
Oh, yes. Thank you so much. Actually, you know, the heart, so you're using HER2, very simple, very easy. Try to do for the breast, EGFR, HER2, 1. For lung, in generally like you, EGFR, L, KRAS, but not PDL1. Most of the patient is very costly, so we in generally know. But if sometimes required, we can go. But very few patients is a little bit costly. For colon also, we use some very common biomarker, KRAS and RAS. But around the BRAF, I am not because most of the time you cannot get available medicine, and like this, the difficulty. But P16 sometimes we're using for the head and neck cancer, it is useful for us. So other common biomarkers, actually for the serum markers, everyone is using PSA, C125, CEA, C15-3, etc., etc. We are using it's very commonly. So these are the common practice in our country. I think my personal view, my hospital, the Square Hospital, I feel my patients are benefit. Particularly, I can say one case to you. One of the patients of medical school, her mother was suffering from lung cancer. I gave her the molecular study, and it came ALK positive, and now she is ketogenic for last 4 years. She is still surviving. So I found there's a benefit. So why don't you do it? We'll try. If possible, patient can able to afford, then we'll try for them.
Baral, can I make a comment, please?
Sir, I'm coming back to you, because this is the question of the day. We represent SAARC countries, and we are comparing our SAARC countries with different, developed countries. So, Dr. Parikh, you are the learned person. You are our teacher. In your view, what is the basic difference in the practice of biomarker testing between developing countries and SAARC countries, sir?
So in developing countries, the biomarkers are tested based on the insurance reimbursement. Okay. If it is approved and if it's US FDA approved, if it's companion diagnostics, everybody will do it compulsorily. In SAARC countries, as everybody has mentioned, it is based on the patient who is sitting in front of us.
Exactly.
How will he benefit from doing the test? And I think that is the fundamental difference. The comment that I wanted to make is that because some of the biomarker tests are expensive and the drugs that follow are also expensive, we need to counsel the patient. And I think this has to be done extremely carefully because, like I will take the example of ALK testing that was just mentioned by Syed. If the test comes back negative, which will happen in 95% of instances, the patient should not start blaming us why you asked for an unnecessary test. So counseling about the likelihood of a negative result and no change in the treatment has to be discussed before ordering the test. And I think this is one communication piece that we should include in SAARC. Back to you.
I really fully agree with Dr. Parikh. He has given two words. One is reimbursement and second is counseling. Regarding reimbursement, in SAARC countries, in Sri Lanka, patients are insured. Every treatment is free of cost. In Bhutan, every treatment is free of cost. In Nepal, we are not in the position. Now, health insurance policy is going on. So probably in near future, something will happen. I don't know what is the scenario in Pakistan or Bangladesh. So is there any reimbursement policy so that patient can get free treatment, whatever the drugs, costly or non-costly, no problem.
So in Pakistan, this scenario is not that much that most of the time the patient has to buy. But there is another scenario that government pays through Baitul Mal, which is a sort of to being given to poor patient. But now the present government is trying to introduce health card so that through that health card, most of the people are going to get these medicines.
Dr. Baral.
Yes, sir.
Yes, just a small comment on that.
Yeah, Dr.
So, yeah, as you know it very much, Dr. Vishnu is also here. So in Nepal, we have some government facility. So government is providing 1 lakh Nepalese currency. Not the money, but the drug or investigation that will be around 1 lakh to each and every patient who has been diagnosed with cancer, any sort of cancer.
But that may be utilized for surgery or radiation therapy or chemotherapy for testing also, whatever.
Also, yeah. So that, and also the government supplies few drugs. Those drugs are very, very quite cheap. Suppose if you buy paclitaxel in the market, it costs about 12 or 15,000 for 260 milligram, but the government, from the government supply, you can have the paclitaxel in about just 5 or 6,000. The same thing like for the target drugs like Gefitinib, like in Beer Hospital, where I do practice as a government employee, that is available. It's a lot of things, Sunitinib, Gefitinib are available from the government fund. So that is the message that I want to say. These are available.
I fully agree, Ambuj, with you. The basic challenge for us as a SAARC representatives to unify to same modality of treatment and in affordable price. So we should all unite together for uniform protocol, low cost treatment so that patient can afford. But those patients who are really affordable, we should give them options. And as mentioned by Dr. Parikh sir, counseling is very important. So any other remarks from any? I have only 1-2 minutes.
Yes.
1 minute I can give.
Baral, I just want to add one thing. Yes, many oral targeted therapy is available in our country, particularly Gefitinib, Alotinib, Osimertinib, even Tisotinib. Our local companies are producing these drugs in our country. So they are also exporting to other countries as well.
Okay, not taking much of time. Let me have some take-home message. The take-home messages are the precision oncology and biomarker testing are complementary to each other. The more biomarker testing, the more quality treatment, the better clinical outcome. we should promote practicing biomarker testing depending upon the patient status. Either he can afford or not, reimbursement policy is there or not, and there is the word patient selection is very important. And why all these testings are needful? Because biomarker testing helps personalize cancer care, a good quality treatment outcome. That is the main intention of the biomarker testing. So with this, let me thank my all esteemed panelists, and my special thanks goes to my dear friend, Dr. Govind Babu, SFO President, my another dear friend, Dr. Amit Bhatt, General Secretary of SFO, and very dynamic, our leader, Scientific Chair, Dr. Purvish Parikh, and of course, Kashish Parikh, for making this all event a wonderful event management, and looking forward to see you all. Thank you very much.
Thank you.
Thank
you, sir. Thank you. Thank you, Baral. Thank you, Bruce. Thank you.
Thank you very much, everybody. That was a wonderful interactive session, and precision oncology, personalized medicine, biomarker testing is so vitally important for us. In fact, we are doing a certificate course for novel biomarker testing, and anybody who's interested can register for the same. I now hand over for the next session, which I believe is sponsored by Roche. Over to the faculty for this session, please. Amit, Bhatt, are you there?
So we are having a Roche video. Dr. Sewanti has not joined, so we can straight away go to the panel discussion. Okay. We're trying to get in touch with Dr. Sewanti. Kashish, you can go ahead with the panel discussion once the meeting is done.
Hi, Gauri.
Noted, sir. Noted, sir.
How are you, GS?
Fine.
Did you take the vaccine?
Not yet. It's not been allotted to my name.
Me, same. I'm in the same boat.
I mean, it's fortunate that most of my people have taken the vaccine in the hospital. So right. I'm pretty glad of that. Okay. Would Kashish invite my panel for me, please?
Sure, sir. I'll just do that, sir. So we move on to the next session. This is the academic session on lung. The topic is lung EGFR targeting, first line and beyond. Our moderator is Dr. G S Bhattacharyya, medical oncologist from Kolkata. His panelists are Dr. Nirmal Raut, medical oncologist from Mumbai, Dr. Chakur Vora, medical oncologist from Pune, Dr. Kshitij Joshi, medical oncologist from Mumbai, Dr. Satish CT, medical oncologist from Bangalore, Dr. Muzammil Sheikh, medical oncologist from Mumbai, and Dr. Reshma Puranik, medical oncologist from Pune. So over to you, sir.
Okay, is my slides visible?
Yes, sir, your slides are visible. So request you to make it full screen. Yes, now it's full screen.
Perfect. So thanks, Kashish. Thanks, Purvish, for asking me to be here. And Babu, thanks. I almost had to drop out because there are too many things in my platter, which I really don't know how to eat or digest myself. So anyway, we all have been talking of precision medicine. We all have been talking of personalized medicine. We are talking about biomarkers. So I'm going to do a first line proof of why this is required, and also show something that beyond precision medicine, there is also personalized medicine. So let's start. I'm going to start putting across to my panelists, there are domains of decision quality. This is from the Medical Decision Making Society, which tells you that whenever we make decisions, and we just heard Baral going through this part, that communication, accessibility, trade-offs, values, reasonable options, and risk tolerance are important. I agree with Baral that even for biomarkers and for treatment. This is just to put it across the timelines that we have been through, how EGFR, when it started in 2004 and 2020, we just went over, where we found combinations of EGFR and VEGF drugs coming into play and getting important. We have come through a long way in the last 15 years, and that's been a long, long time that if you look at it, how we went through. So I'm going to start with the case. A 63 years old, never smoking woman presents with shortness of breath, cough, and weight loss. Chest X-ray reveals the right upper lobe opacity. Follow-up CT scan of chest demonstrates 6 centimeter upper lobe, a mass, mediastinal adenopathy, bony mets, and thoracic spine. CT guided biopsy not entertained as patient refused. It was thought of, but we couldn't do it. Instead of patient was put into EBUS FNA for mediastinal nodes. What next? Anyone? Hello. Hello.
So we have 3 panelists currently online: Dr. Satish CT, Dr. Reshma Puranik, and Dr. Kshitij Joshi.
Okay. Can you just give me the names once more, because it's all.
Yeah. Sorry, sir. I'll just repeat. Dr. Reshma Puranik from Pune, Dr. Kshitij Joshi from Mumbai.
So I'll just say Dr. Reshma,
yeah,
Dr. Satish.
Kshitij and Dr. Satish.
Okay. So let me start with Satish. Satish, what next? Once you have this in front of you and the biopsy is done. Satish. Okay. Satish, can you hear me?
Yeah, I can hear. Yeah, sir. So
Okay,
now in
Satish,
this case,
Yes, sir. In this case, it is a definitely lung cancer is there. We wanted a proper tissue. That is the most important actually, because it's being a female, and we wanted to have we wanted to extract tissue for a biomarker. That is more important. Proper tissue obtaining is more important. And the basic biomarker test, what I wanted to, because being a non-smoker and woman, we'll try to get the a EGFR ALK RAS1 is one thing, is a priority, we'll try to get it. And if all things are coming negative, we can get a PDL1, and later some other markers also be done, sir.
Okay, means you don't send for the PDL1 to start with.
Then no, sir. First one thing is priority is EGFR is the one thing. First.
Okay, fine. I accept.
Yes.
So anyway, you need to distinguish between small cell and non-small cell. So you do a IHC marker for that. You do a NSC subtyping. And as you rightly said, hello.
हाँ, तू join करता है कहाँ?
Amit, I'm already joined, Amit.
Guys, sir, please go ahead, sir.
Okay. So anyway, and that's the list of marker that we have that we should be doing upfront by the guidelines that are being published all over. Yes, we need to adapt this guideline and make it into our own key, rightly pointed out what we can handle best. And do the PDL1 only if negative. Patient was TTF1 adeno positive, was adenocarcinoma. 2 days later, the PDL1 came as 95. NGS results were not out as yet. What do you do now?
Yeah,
and patient wants to start treatment right now, and these are your options. What do you do now?
So I like to start on patient is symptomatic. I like to start on chemotherapy. Then based on the if other driver mutations come negative, and next cycle onwards I may add immunotherapy. Otherwise, I'll try to I may not start immunotherapy as a first line, because if the driver mutation comes, but there are incidences there, even PD-L1 positive and EGFR.
We'll come to that later, Satish. So you want to start chemotherapy.
Yes,
so you have to counsel the patient, because the patient wants to start immediately, and she has the PD-L1 report.
Yes.
Satish, you want to add something to this?
Yeah, I'll try to start because patient symptomatic and patient is in a lot of worries are there, no treatment is started. I like to start on cytotoxic chemotherapy, that is a Femitex platinum based treatment.
Rashmi, do you want to agree to this?
Yes, sir, I agree completely. I would also start off with the chemotherapy first and wait for the molecular testing before I guide the patient further for TKI or immuno. So I'll also start with chemotherapy.
Absolutely. So your best choice is wait for the results.
Yeah,
patient is...
Yes, I try to counsel them this is a beginning basic treatment will be there, and I'll talk to them. If the EGFR comes positive, I can add a current to the current regimen. I can add a oral TKS also if possible, if immunotherapy also. I'll talk to them.
Okay, fine. So question remains is your options are two: wait for the PD, if you can convince her to wait, which is going to be difficult, or you start the chemotherapy. Unfortunately, this patient said, I am PDL1 25% positive, and I want you to start with chemotherapy. So we started with the first Bremo based, and then went into the report came as EGFR activating mutations positive. I'm going to tell you something and make a bit of a complicated slide is not there. Had this been 50% PDL1 positive, would you have started immunotherapy?
No, sir.
Okay, Satish, fine. Rashmi?
No, sir. I would have still, if it is EGFR mutation positive, I would have liked to start TKI only.
Okay, before we move into that part, I'm going to ask you, I want your take on liquid biopsy. I'm sure you're all practicing liquid biopsy. So Rishma, to start with you, what do you think about liquid biopsy?
Sir, if a tissue biopsy is possible when the patient comes to me as a new patient, so I would prefer a tissue biopsy only in those cases where it's difficult, it's not accessible, patient is comorbid or refusing an invasive procedure, then liquid biopsy would be my second choice.
Satish, you agree with her?
Yeah, definitely I'll agree with her. If histopathology is there and if a tissue is there for additional molecular test, I'll agree with that. I'll try to obtain the tissue for the most likely for the as much as possible. There is a situation, performance status is not good, patient is not willing, and we are not able to. There are situations they're not keen for an invasive like EBUS procedure, central lesion, difficult to take a tissue diagnosis. I'll try to go for liquid biopsy to take this one.
Okay, fine.
Yes.
So currently, can I add something? Currently, the same I agree with everyone. Currently, as per the sensitivity, what I know is the liquid biopsy concordance is 80%. So always we would prefer a tissue biopsy, and only in the second line, suppose a patient progress.
Kitesh, we'll come to you. Let's go through this. Well, we now have some data that's come in quite some time back where they say that the net positive value can move anywhere between 90% to 100%, depending on what type of mutation you're looking in case of liquid biopsy. The other part of it is that based on this, the algorithm, which is called the Charu-Agarwal algorithm, which has been developed to tell you that suppose we cannot do a biopsy, where we do it. Okay? And then finally, now we have a particular situation that we need to get something clear that the net negativity rate can be false. One, okay? Two, the simultaneous addition of plasma may actually add something. And if you watch carefully, we will realize that we do have almost 35 out of 82 people who are extra on the liquid biopsy. All right. And then finally, hello?
Yes, sir. We are.
I don't know, something seems to be wrong. Okay. So those are the things that we had there. And high predictive value, but it is imperfect. And I do agree with you. It should be used only if you cannot get a tissue. Otherwise, it is always a supplement to the tissue that we are talking about. All right. All right. So what next for this patient? Now that we had started Pembro, what do? Stop the Pembro and go in for TKI? Or continue the chemotherapy, stop the Pembro, add the TKI? Or just add the TKI and stop everything?
So this case, like I'll try to go with adding a TK if is going for a first generation, like especially Jeftinib video where having data is there. Otherwise, the patient, patient is responding to the chemo, I'll continue chemo with adding a Jeftinib. Otherwise, not keen for interesting for a IV chemotherapy, I'll try to change to Vormatinib. Take this. So this is the plan. But only thing is, I'll try to meantime I'll explain them. Those are having EGFR mutation, PD-L1 expression, they don't do well like as those are having a EGFR mutant positive, PD-L1 negative.
So for my panel, I'm going to give everybody a take-home message. Targeted therapy for actionable drivers, chemo or immunotherapy for everyone else. Because there's enough data to tell us that if you are going to give us upfront, first line immunotherapy to a patient who has got a driver mutation and a proper driver mutation, actually you can do harm to the patient. And this data also tells you one more thing, that if you have started immunotherapy and then go ahead and give chemo, your TKIs, in fact, you land up with more toxicity. So be careful. The take-home message is all cancer patients should be tested for mutation and approved drugs are available for mutation if the patient wants treatment and can afford the treatment. One. Two, immunotherapy should not be offered upfront to any patient who's got druggable mutation. Plasma-based testing is indicated for patients at advanced stage who cannot get a tissue. It's infeasible or insufficient. Plasma-based testing must be considered for every patient in advanced stage. And that is important on today's date. It may help you to monitor the patient. Okay. I'll just add a new flavor. we talked about doing this tissue. We now have something which is called radionomic detection of EGFR mutation based on AI. It's got a close to 88%. This is just for people's information. It's out last week. This is something important, which may change our method of thinking and maybe a new way forward. So what's the impact of EGFR TKI on survival? Let me start with Reshma.
Sir, we have had a lot of trials, but there was so much of crossover that we were not able to demonstrate the OS benefit. But definitely they are having a very good PFS benefit, and OS benefit is also, but just because of the crossover, it is getting masked. So in the EGFR mutated setting, TKIs definitely have this OS benefit.
Sitesh, you all agree?
Yes,
Yeah,
I'll
this
definitely agree with
osimertinib has shown
Yes,
some
sir.
OS benefit, even in better in the CNS metastasis.
Right.
So definitely we would like to use osimertinib whenever it's possible.
Perfect. We'll come to you on that again, Dr. Joshi. So, well, I'll tell you one thing. If you look at this graph carefully, anyone who's got a targeted therapy and has got a driver, the survival benefit is very clear. And it has made a big difference. So what are the available EGFR TKIs? And that's our list. And it tells you on which drug it works where. I'm not going to get into it, but except that tell you is first generation, second generation is how reversible or irreversible it is.
So Dr. Vora has also joined the panel, sir.
Amish, have joined?
Dr. Chakor Vora, sir. From
Okay,
Pune.
Chakor. Okay. So now let me tell you, this is how we have moved. From IPAS, 9.5 months to Flora, 18.9 months is how the TKIs have moved, first generation, the second generation, and finally the third generation, and that's Flora. You're right, Dr. Joshi. This improvement has been definitely a great important. And now, please remember, it does and has made an impact. So the current approvals and
So sorry
indications.
to interrupt you, sir. Your slides are not moving, sir.
Yeah, there is a problem with the screen. I can't see the slides, sir.
I'm moving my slide. I can see my slides moving. Where are you stuck right now?
So we can see high. So we can see high PPF for NGS panel, sir. So we're on that slide.
Okay. So let me try start sharing once again and see.
Sure, sir.
Yeah, that will be great, sir.
Okay. Is it visible now?
But I still see the slide which says high PPF for NGS panel.
Same.
It's not available, sir.
So sir, I'll just unshare your screen and yeah. So you request you to share it again.
Okay. Can you allow me to share the screen?
So you can share the screen, sir.
Something is wrong. Someone else is sharing the screen. And that's the reason why I can't.
Sir, currently no one's. Sir, I'll do one thing. I'll just withdraw the co-host permission and just make you the co-host again. So you can try again, sir.
It says you're okay. Let me see now. Is it clear?
Yes, sir. We see the slide, sir.
We can
okay,
see.
Fine. We'll just go through quickly and get into that part. All right. Okay. So the available TKIs that we have just gone through them, and this has been the impact of the TKIs. Is this slide seen? Current approval and indications of TKIs?
Yes, sir. Visible.
Yes.
Okay. So this is what is in gamut and shortness, what it is, and I'll not get into it. flora, which was pointed out by Dr. Joshi, has shown survival benefit. There is an issue, I'll come to that later, and that's my take on it, that it's now a preferred TKI in inverted commas. The data looks good. There is a possibility, but it's not the only way forward. Because I'm going to show you something about the flora data. How effective do you think it's in Asians? You can see that graph there, Asians versus non-Asians. I'll start with you, Satish.
Yes, sir.
You can see the graph for Asians, 196 deaths in 47 patients versus non-Asians.
Yeah, like
this is the flora data, the final data that was published. So I'm asking you,
yes,
that's
sir.
Asian versus non-Asians.
I'll agree with you, sir. Like Asian data, like compared to non-Asian, the difference between the survival graph is less. Like Asian, non-Asian people, definitely that you can see definitely like the graphs are wide open. Like here, there's a marginal difference. DSR ratio was not significant.
Reshma,
yes.
Satish.
One more thing is I want to talk about regarding the clinical current of what we are having a lot of number of patients. First, we didn't have a very good, very satisfactory what we are replicating the clinical, what is the clinical study. We are having a lot of first line patients. Second line we are okay, but we are definitely not a very satisfactory result. What is replicating for our study?
Fine, perfect. Yes, Rashmi, Satish, do you all agree with this? That the yes. Asian data is something awkward in India, we should be careful?
Yes.
Dr. Vora?
Yes, sir. I agree that we need more data, or like we need our own studies to decide about it, or we need Indian data basically in this front.
Okay.
Yeah, the Asian must be the Japanese, and this one, the yes. Indian data will be more useful.
Yeah, yes. Absolutely. So what affects outcome? The ethnicity, because I'll tell you that data is actually the Japanese data which is clouding that whole Asian data.
Yes.
When you tease it out, right? So that is one. Two is that age also makes a difference when I look at it, and the type of mutations that makes it important, and the performance status, presence or absence of brain metastasis, and the drug which is used up front, and the drug-drug interaction. I'm going to now tell you, suppose any of the EGFR TKI using gefitinib, afatinib, okay, or you're using erlotinib, or you're using osimertinib. Tell me, what do you tell your patients and how to take the drug? So this is in first line, beyond first line. What do you tell the patient regarding his time of intake and the way he takes the drug? Let me start with you, Dr. Vora.
For erlotinib, gefitinib, first line TKS, obviously I tell them to keep a gap with the food, like one.
How much? How much?
So 2 hours after food, and one, like the tablet should be taken 2 hours after breakfast, and after the tablet, the patient should take at least 1 hour gap to take the lunch. So
Satish, Satish, Reshma?
Yeah,
I'll agree.
Yes, sir. Like I'll agree with him. 1.5 hours, like like should not be immediately up with the food.
But now let me tell you something. The data tells us that it is supposed to be in fasting state. So if it's with fasting or with food, it's clearly said. If you're talking about erlotinib, it's with fasting. So it's got to be an early morning empty stomach dose. And please remember, don't use a PPI or don't use a H2 blocker with these drugs. They grossly interfere with it. So timing is important. Use a gefitinib or erlotinib early morning. With afatinib, 1 hour or 2 hours after food. With osimertinib, you can do anything because the data is not clear there. But there's something I want to tell you all. Suppose you have hepatic dysfunction, and it's more than grade 2. Avoid erlotinib, avoid gefitinib. And if the patient is having any form of steatorrhea, do you all agree with me on this? I have the data in front of you all to tell you all that this is what we should be doing to give the drug. Do you all agree with me?
Yeah.
Satish?
Yes, I'll agree with you, sir. Definitely agree with you.
Reshma?
Yes, sir. Yes, sir. Agreed, sir.
Vora?
Yes, sir. I agree, sir.
So we take home. We will take the drug in empty stomach, specifically erlotinib, gefitinib, right? We'll avoid the PPIs and the antacids if possible. With afatinib, we'll follow the manufacturing thing of 1 hour before or after. With osimertinib, it is fine. Don't use in presence of hepatic dysfunction. This is also to tell you, be careful when you have this drug-drug interactions. And this is why I brought it up is, you may have a patient who has got a brain metastasis. So be careful in choosing the anticonvulsant. Be careful in choosing the antifungals. And be very, very careful. And I want to tell you, this is published data telling you proton pump inhibitors, antacids, they decrease the TKI activity, don't have them. Similarly, you have phenytoin, which does the same thing. The rest of it also can do it. Okay? So I'm not going to get into this, but I'm going to get into a part is, what is the risk of thromboembolic events in a lung cancer? Joshi, tell me, what do you think? Joshi?
Hello. Yeah.
What do you think about thromboembolic events in lung cancer?
Yes, sir. We have seen few of cases, but not very common.
What do you mean a few of? Any rough idea?
The tumor is means like a mediastinal mass and upper these things.
Okay. Sitesh, Rashmi, you all see lung cancer with?
Yeah, definitely. I'll see clinically routinely, like roughly around 10 to 15% of cases.
And with EGFR, how do you see it?
Less common.
We're not
Around
seeing
10%, so we have seen 10 to 15.
With EGFR TKI?
Yes.
Okay, let me tell you, with EGFR TKI, with EGFR, the chance of a VTE is higher. So there is a role for using an antiplatelet or a blood thinner in this. This is more so true with osimertinib. This article has just been published again, as I said, and do check it out, it'll be available, okay? What about age? What's the impact of age? Suppose I have a 75 years old and I have a 55 years old TKI. Who do you think will do better with the TKI?
So the elderly patient tolerate the TKI better, like the gefitinib and all is very well tolerated. I've seen a very good tolerance of gefitinib with these elderly patients.
I agree with you. In fact, the elderly does better. In fact, if you have, it actually overrides the age as a negative predictive factor. Anyway, what sequence would you use in a EGFR positive? Like, now we just talked about the osimertinib data. What would you like to do? First line, second line first, and then osimertinib, then chemotherapy, or what would you like to do? Can you tell me? I'll start with Joshi. Joshi again.
Yeah, but in practice, I usually start with the afatinib and then whenever it progress, I try to use osimertinib 5790 imputation positive. But as per the data nowadays, we can also start with the osimertinib, which has a very good data. And if it progress depend on our next mutation analysis, we can choose either chemotherapy or next.
Sitesh, Satish, Reshma, you all agree?
No, sir. In my, I have whenever the patient is affording, I will definitely give him the option of osimertinib because it has had such a good PFS benefit and also showing a good OS data. So I will definitely give an option of first line osimertinib. And then eventually, if the patient progresses, then there is a choice of chemotherapy, of course. But if we avoid osimertinib in the first line and then there is no T799, then the patient never will get benefit of this drug. So I want to offer this to the affording patient in the first line also.
Sitesh, Satish, Vora.
Like my practices, I'll agree with Reshma. Pattern is slightly different. That is a affordable patient. They want like a best one option. I'll give you option. Everything day one I'll discuss with the brain meds. All those things I'll try to prefer osimertinib is the one option. Those who are not affordable poor patient, like they're not willing to come to the hospitalization. All those things I'll go only first generation TKA. Like the gefitinib, like there's a one thing I'll try to prefer. Otherwise, there are people, they're middle class, they're not able to afford at all. They want like options. So like I will try to have that the combination of chemo plus gefitinib. This is my practice.
So anyway, this is what is, you have two options: start osimertinib up front, or start with a EGFR TKI 1 or 2 in the beginning, and then add osimertinib or chemotherapy as the progression starts taking place. Right? The best part seems to be possibly starting with the first generation, then moving into osimertinib and chemotherapy. And I'll try and tell you all something. Watch this graph carefully. Most of the study has been done in real world data. Okay. And most of it is now based on what I heard Joshi made. And I'm really impressed because this is the Go data. The Go data says afatinib upfront, followed by osimertinib, right, may give the patients the best results that we are seeing. And this whole study actually has been done in Asia. And it's a major thing that's coming up in this manner. We might see it in the guidelines that come up very soon. But as of now, choose your drug by your capability. You can actually use osimertinib up front or go sequential as it is. So now the concept of delay resistance.
So
To the
5
EGFR,
minutes left, sir.
yeah, I'll just finish. Dealing this resistance so that we can delay everything. What are the opportunities that you have with EGFR TKI? Vora?
I just missed the question, sir.
We all know at the end, all TKIs, whether they're given in EGFR, are going to mutate and further cause resistance or change the character of the tumor. How will you delay this resistance?
So delaying resistance. So the one thing which we learned from the data was like gefitinib plus chemotherapy. So that is one thing which has shown improve the progression-free survival. Another thing, combinations with the VEGF inhibitors. So those can also be tried with. Those are being tried in different studies. So these two things which are there, we can consider it.
Okay. Let me try and tell you, we have alternative with bevacizumab also.
Yes, sir. Yeah. So basically,
We have,
TKI plus VEGF inhibitors.
yeah. And Reshma, what do you think? That suppose if you had a chance of giving anybody erlotinib with ramucirumab on today's date, would you give it?
So we just have a very preliminary data, and it is showing a small PFS benefit. So not very keen on this as of today. Not very keen. So.
This data is almost as good as osimertinib, if not a bit better. Yes, it's an injectable drug there, it's an anti-angiogenic drug. But this data, and this is the approval for the drug on May 20th combination.
Would like to wait for more.
So you would like to wait for more data. Absolutely
OS.
fine. But this is one of the methods besides chemotherapy allowed. And we have our own data from Anita, which says that what we are supposed to do, right? And we have this as we just heard about it on the graph. Okay. But I will tell you one thing that I personally think that we have come to a time when we need to look for it. Patient progresses, oligometastatic, EGFR mutant, on erlotinib or gefitinib. What do you do?
Oligometastatic, sir, we can biopsy the site, and we can obviously we can give local treatment. But the data whether we can continue the same TKI, that we are yet not sure about.
Reshma?
Sir, agreed. So we'll do the biopsy and try to treat it with local, like for example, local radiation, and continue the same TKI.
So perfectly, I agree with you all. No clear benefit for progressing on TKI with chemotherapy if you're going to give chemotherapy. But if you want to continue giving something else, fine. But I want you all to remember something. Look at this part clearly. If the oligometastatic is approachable by local therapy, right, then a radical radiotherapy or surgery may be indicated to actually give you the maximum benefit. There is data to this effect, which says the local control may actually make a PFS difference of 14.2 versus 4 months, and overall survival between 41.2 versus 17 months. So it's very important to know what sort of metastasis do you have. Jumping to change the TKI or adding chemotherapy may not be the right form if the other parts are actually doing it. Now, so I mean, I think Kashish gave us a warning. So I'm going to actually now sum up. One, if you have a EGFR mutation, then your target is always to use a anti-EGFR drug. Two, you can use any one of the drugs upfront depending on your situation where you are comfortable with. 2, 3, sequencing may be very important. 4, in case of unusual mutations, there is good data for osimertinib and for afatinib. 5, please watch out for mutations. And one of the methods of watching out is by screening. And the second method of watching out is by doing repeated liquid biopsy to find out where the mutations goes. And this is just to tell you when we do find a mutation where we move. And that's the other method of looking at it. What's coming up in a big way, the osimertinib VEGF, osimertinib with chemo, and finally osimertinib with local control. We just had it. And with this, I will stop. If there's any questions from the public, please go ahead.
So we have one question from Dr. Riju Sharma. Sir, if you're able to read that in the chat.
I'm not being able to read it.
Sir, I'll just say the question. Where does afatinib stand in the era of osimertinib, especially in patients with no brain mets?
Wine, Joshi, go ahead. I think you had started the discussion. I only ended it. Tell me.
Yeah, there was some data that you have already discussed, sir. Yeah, afatinib followed by osimertinib given a very good result. So that GEO some study. So because of that and this nowadays afatinib is quite easily available at a low cost, and practically this is the most preferred option nowadays in our practice.
It's 54 months versus 41 months of osimertinib alone up front. And after osimertinib, afatinib doesn't work. So that is an important thing that we have as a method.
Afatinib is also useful in some uncommon mutations.
Absolutely. And second part of it is that when you have the HER2, HER3 mechanisms coming up for control, right, of escape the control, afatinib does play a role
there. Thank you so much, sir. Due to want of time, we'll move on to the next talk. So I'll like to introduce our next speaker, Dr. Sewanti Limaye, medical oncologist from Mumbai. The topic is immuno-oncology in lung cancer. Over to you, ma'am. Ma'am, you'll have to unmute your mic. There you go.
So, a very good evening to all. The topic that I have is actually different. So I'm going to whatever I got is what I'm going to present, because now it's 99th hour and sharing my screen. So the topic that I got was to present immuno-oncology, what I do at my hospital, outcomes in NSCLC. So I am just going to share what we do at our center. Hope that's going to be okay with you.
Ma'am, that's the topic, ma'am.
Yeah, that was the topic. That's the only topic.
All right. You got it all wrong. So I'm just going to share some of our experience here at Ciclibs Hospital, and thank you to the organizers for giving me this opportunity. An honest confession is that we don't have the data all mined, so I will not be able to give you survival data for our retrospective analysis. But in general, the theme is similar to what Sir G S just discussed. And when we have an advanced lung cancer patient, what do? So most of these patients come to me with a few of these biomarkers already tested. And when I say a few, a lot of these patients may not have BRAF tested. So BRAF has not caught on yet. But most patients will come with EGFR, ALK, ROS, and PD-L1 test already done. I would say around 25% to 30% of these patients don't come tested, and then I have the opportunity of deciding what tests they will get. So mostly, I would say 90% of my patients, I do a broad panel testing for these patients. I do DNA, RNA, as well as MSI, TMB. Unless the patient already has in their kitty, and that is positive, and that's mainly based on the costing. If you break the cost, each gene and PD-L1 separately, the cost mounts. And if you do a comprehensive thing as a lung panel, the cost is lesser. And so that is what I do. I mostly send a lung panel. My tests generally are comprehensive. Even if a patient has come with an EGFR that is positive, I would still do sequencing at the back end to understand the complete molecular biology of that patient. And that's mainly to sort of try and understand how the course of the disease is going to be. So once you have established whether the patient is a driver mutation or a non-driver mutation, you can think better in terms of what's to be given next. However, it is also a reality that now we have a whole host of driver mutations. When I have a driver mutation that does not fall in the category that was enlisted on the first page, which is the standard of care, which is these 5 biomarkers. If the patient doesn't fall in this category, then automatically the patient, if the patient doesn't have the 4 driver mutations that were listed, then automatically the patient gets offered chemotherapy, and chemotherapy plus or minus IO. And the other question is, if the PD-L1 is very high, would the patient be a candidate for IO alone? So we have we have one first-line trial already running. It's closed for accrual. It's atezolizumab in irrespective of PD-L1 status in frail lung cancer patients, frail and elderly lung cancer patients. We have ongoing patients on that, on atezo alone, in partial response or complete response. And there are some who progressed and have been taken off the study. And then we have the pembrolizumab phase 4 study running, where in first line, if the patient has a PD-L1 above 50%, we can offer single drug pembrolizumab. Off of the trial also, my routine would be to look at the PD-L1 status, and if the PD-L1 is high, looking at the disease burden and whether or not adding chemotherapy would be meaningful, or offering IO alone would be meaningful for that patient. So in general, for the 4 driver mutations, EGFR, ALK, ROS1, and BRAF, that's how I decide. But if the patient is not driver mutation, these 4 driver mutations are not met, then I would in general send out the comprehensive analysis and consider starting them on chemo-IO, depending on what their signature is. Having said that, now as I have I'm maturing in my practice here at Ciclibs Hospital, more data with driver mutations is coming through. And this slide is mainly to demonstrate that now I've started thinking, thinking more than these 4 driver mutations. And I usually look out for what else can be found in the comprehensive analysis. And I may actually, if the PD-L1 is low and I cannot offer an IO alone to such a patient, I may actually just give chemotherapy and wait for the comprehensive genomic analysis to come back, and then decide whether I would like to offer IO to this patient or not. If it is a patient who has, so if it's a female non-smoker or even a male non-smoker, my thought would be to really hunt very deeply for a driver mutation, because of my understanding that driver mutations behave differently. And this is an illustrative slide by Dr. Martin Thomas from Heidelberg Cancer Center, that I borrowed his slides here because I found it very interesting. If you look at immunotherapy and how different driver mutations behave, there is a significant fallout for patients who are not even the first 4 driver mutations. We talked about EGFR, ALK, ROS1, and BRAF. So if you look at immune checkpoint inhibitors and what kind of response you would get, the numbers are actually low for EGFR, ALK, ROS1, and even for BRAF. When you go to HER2 mutant, MET mutation, RET mutation, really the numbers are low. So today, I think we are waking up to the understanding that if a patient especially in the Asian background, is with a driver mutation, maybe adding an immunotherapy without thinking too much may not be the correct thing to do. And it's a moment of pause, and one has to really consider appropriately before proceeding. And maybe adding chemotherapy to immune checkpoint inhibitor for these patients, and maybe the regular rules don't apply. And even I've thought of the Empower regimen in these situations, which may be better than just offering chemo IO. And these things are not still out in the in a standard of care setting. I think the world is evolving, the lung thought leaders are evolving, the clinical trials are evolving, but this is a realization, and more so because the Asian experience is going to be very different. So we collected data for the last 2 years, and in that there are 185 cases that I have treated with for different malignancies, including lung cancer. And initial data was in 35 lung cancer cases, and I have 6 ongoing cases for lung cancer. So I've just put them together here, 41 cases in total. 4 were small cell lung cancer, 5 adeno and 2 adenosquamous. And there is IO alone in 13 patients, where we gave Pembro or Atezo on clinical trial, 1 patient outside of clinical trial, 5 cases with CTRT followed by durvalumab. 2 of them were on the Pacific 2 study. 22 cases with chemo IO and 2 cases with the Empower regimen treated here at our center. Some of the cases that I'm just going to show it to you here. This is an NSCLC patient with extensive smoking history. And this is one of the first PET CTs with positive disease. And then even though the patient is NRAS mutated and had a significant history of smoking, driver mutation negative. So this patient had excellent response and continues to be in remission. There's a and this image is of osimertinib failure. So the patient comes in with osimertinib failure, was biopsied, and was found to have transformed to squamous cell carcinoma. And on liquid biopsy also no clone for EGFR. And on biopsy also EGFR negative. So the entire EGFR clone had died out. And really one was nervous about stopping the EGFR versus continuing. She had very high PD-L1 status, and from that perspective, disease, she was started on chemo plus pembrolizumab and had significant response and went in complete remission, remains in remission on single agent pembrolizumab maintenance. She was treated with carbo-nab paclitaxel. Another patient here was NSCLC, but non-smoker. Remember, non-smoker, female, NSCLC, adeno driver mutation negative. And this patient actually had a PCR-based, COBAS-based testing for EGFR. Alcross was done by IHC, and PD-L1 was, I believe, 30%. And then she had a broad panel sequencing, NGS also done, like I do for most of my patients. And all of that was negative. And this patient was started on chemo plus Pembro. And you have recurrence, failure, and then rebiopsy. And at this rebiopsy, 2 places, NG one of the things that I was very wary of when you switch from immuno to targeted therapy, osimertinib TKIs, there's chance for pneumonitis and hepatitis flare, and there's 2 months of gap that you have to give in between, but this patient had so much disease burden, there was no way that I could have given a gap. So either I could have gone to a second-line chemotherapy, or I could have given osimertinib under very close observation, and that's what I did. I prepared the patient. I did like weekly follow-ups, interaction or communication with the patient, also did very close liver enzyme monitoring. Patient didn't have any issues and went right from chemo IO with, she required whole brain radiation and then osimertinib. So this is a patient where rebiopsy, so both the cases, the last 2 cases, rebiopsy really helped, resequencing helped. This is a third patient with adenocarcinoma driver mutation negative and develops chemo pembro failure. Actually, sorry, that's a typo. So driver mutation negative, so sequencing done. Sorry about that. So this is a typo actually. So this is a patient who had driver mutation negative and was started on chemo plus pembro. There was no failure, sorry about that. So this patient on Foundation 1 testing has KEAP1 and STK11 positive disease, but this patient responded. So, just showing a point, showing the slide to make a point that KEAP1 and STK11 are controversial. We know that there is some data saying KEAP1 and STK11 may not let the patient respond as well to immunotherapy, but this patient did respond. I don't know whether the momentary response is from this is a very short-term follow-up, is from the IO or chemo, but the chemo was given in a very reduced dosage. This is another patient who had NSCLC adeno with ERBB2 mutation and went on therapy with chemo plus pembro based on Keynote 189. And after the patient was put on maintenance with pembro and pemetrexed, developed progression in the lung and in the liver. Pre-treatment, when I said pre-treatment to poziotinib, so this patient was put on poziotinib, and you can see the wonderful response. So again, this slide is being shown to drive home the message that if a patient is driver mutation positive, depends what driver mutation we are talking about, So driver mutation positive, you really have to think which driver mutation and how long, and it's always better to prepare the patient. So if you have ERBB2 mutation, or you have exon 20 insertion, these are bad behaving alterations, and these patients will have progression. We have multiple patients that we are treating for stage 3, and this is a patient who remains in remission on stage 3 durvalumab maintenance. So my usual style for most of my patients is to consider driver mutation testing, and I do a very detailed analysis mostly until I really understand the patient appropriately. My style is to test, and mainly the testing is for being able to establish if the patient falls in the category of difficulty with responding to chemo plus IO. And in situations like these, I have actually erred on the side of caution and added the BEV, which means I didn't show you, one of my patients is actually KRAS positive. And on chemo plus pembro, developed oligo progression. And for that patient, the only change I did was to add BEV. Because I knew so he had a completely negative scan. The first scan was completely negative, and second scan, oligo progression. So added the BEV, again, the patient is in complete remission. So BEV, pembro, IO maintenance is ongoing. the Bev, Pembro and Pemetrexed maintenance is ongoing. The idea is to stop Pemetrexed down the line to make it more tolerable for the patients. So core and center is the fact.
Ma'am, sorry to interrupt you. So, ma'am, have you unshared your screen?
I have. I'm
Okay.
done with my presentation. I'm just finishing.
Sure, sure.
Core and center is the fact that we have lung cancers in India where phenotype may meet the criteria of driver mutation positive disease. And that's where what GS sir said really is very critical for us to look enough to find that driver mutation in order to understand the biology of the disease. And if the biology, disease biology points towards a driver mutation positive, you have to look enough, figure out which driver mutation, and then lay out your expectations from the therapy that you're offering to the patient. So chemo plus pembro for a smoker, non-driver mutation positive, you then fall into the expectation of 189 versus chemo plus pembro in a phenotype that is smelling of driver mutation, but you couldn't find any, may not have such a long-lasting effect. So these are the things that are central to how we have been practicing lung cancer treatment at Cochrane Hospital. Recently, I had a RET mutant patient, and again, you recognize that these patients will not have a long-lasting effect, and so if the disease burden is high and you don't have a RET inhibitor in your kitty and you need to start chemotherapy, my thought is to then look at the Empower regimen and not just the Keynote 189 where you give chemo plus IO, and I would go towards chemo plus IO plus BEV in such patients. So thank you so much. I hope to have shared some insights, and more importantly, I hope to have given the right talk. Thank you.
Thank you so much, ma'am. You've in fact given the right talk. So we'll move on to the next session. Our next speaker is Dr. Anita Ramesh, medical oncologist from Chennai. And the topic is which is the first among equals. Over to you, ma'am.
Yes, sir. Thank you so much. And thanks the organizers and Dr. Baral. Nice to see you from Nepal. Thank you. Hi. Hi to everybody. Hi to everybody. Yes, thanks a lot. And let's move into the Ciclibs. Actually, I did have some time to understand what you meant, but then slowly I think I also should be able to give the right talk. Now, which is among the first among the equals. So let's move on to, let's see what the CDK4 and 6 inhibitors do. We'll talk about premenopausal, we will talk about the postmenopausal in the hormone receptor positive, HER2 negative subset of patient. And the Globocon 2018 and the recently Globocon data also got released showing that more than 10% incidence in the breast cancer and the mortality rate is still around 5%. And India, it now ranks the first cancer incidence and high mortality. And so it's a thought process as yes, we need to really address it. And there are so many women who will be dying if we are not going to address them properly. And in a metastatic landscape, 30% do have disease which spread and are around 10% do present at that stage when you are metastatic at diagnosis. So what we are at this point of time looking into is that 61% of patients who are hormone receptor positive and HER2 negative. And this spectrum may have a huge spectrum. We see somebody who rapidly progresses with a short interval, extensive meds, and do get resistant faster to the endocrine. And that's the saddest of the population, whereas there is some subset of patients which go for a longer time, has late recurrence, have bone mets, and soft tissue or single meds. And that's where, again, these drugs will be also a big armamentarium in our treatment. So let's look into the history starting from 70s and now we are in 2021. We have the AIs as well as the CDK4 inhibitors. We have the ribociclib, palbociclib, as well as abemaciclib approved. And if you read the literature, there is almost more than around more than 20 CDK4 inhibitors are online. So that's the diagram showing, which shows the signaling transduction pathway and shows the cell proliferation, and where we regulate the G1S phase is the real checkpoint, and it's there. If you see the diagram, and there are too many pathways involved, and that's what we are targeting. One of the first CDK4 was Palbociclib, then we had Ribociclib in the market, and now we have Abemaciclib. So that's why we brings us to the discussion, which is, are they all same or which one to use? Palbociclib was the first one, and it was a paradigm shift. We had a lot of meetings, talks, yes, how to use it. What is the best one? What about Ribociclib, Abemaciclib? What evidence to have? How do we compare? Which is most potent? How is the overall survival data, and what are the toxicities which help us to? So let's quickly go into, in the short time period, I'll just try to focus on a couple of studies. Now we know the Monarch restricts itself to Abemaciclib, Paloma with Palbociclib, and the Mona Lisa with the Ribociclib, with the premenopausal, postmenopausal hormone receptor sensitive. You see the couple of trials: hormone receptor resistant trial, hormone receptor resistant, no prior therapy, one prior therapy, multiple prior therapy. So Monarch addressed the multiple therapy, and that's the landscape of how many trials each looked into. And even if you see the Mona Lisa 3, it looked into both the sensitive as well as the resistant. So this gives us some of the idea as how to proceed with this. Now, quickly, a differentiation between that, and if you see the that's the schema which looks like, if you are, these are the trials which addressed, again, a little modified version of the previous slides, where Paloma 2, Monarch 3, Mona Lisa 2, Mona Lisa 7, and Mona Lisa 3 has an extended, goes up into endocrine resistant. So since all the drugs had a wide patient population to study to give us a report, and that's the it's a little busy site telling us what is that. Now, in a premenopausal moment, if you see this, you have the Mona Lisa 7, Monarch 2, and the Paloma 3. And Mona Lisa 7 is the only study that was dedicated exclusively to the premenopausal, where Monarch 2 and Paloma 3 did a subgroup analysis to see what is their outlook in the premenopausal patients. So it's not that the postmenopausal, but we do have the premenopausal also people into the consideration. Now, that's the Paloma, one of the basic study which looked into those who had a prior, and it was seen in the first line therapy, and that was one of the early trial which showed that the efficacy, safety profile, and it showed, and you see how the curves diverging, and that all gave us a lot of big hope in the future. Yes, we have something to do, and with a significant progression free and survival. And that's the Mona Lisa 2 we have seen in the hormone receptor positive patients, and again, which was published in Annals of Oncology, did express a difference in the progression-free survival in the investigator assessed. So, and the Mona Lisa 7 we just went through, okay, that looks into the, again, assess the investigator assess progression-free survival. And in the Mona Lisa 7, there was an OS in all the patients. That was the key secondary point they looked into, and 29% reduction in the risk of death, and the p-value was superior, okay, and had a 42 months. So the generally consistent with overall survival benefit at all subgroups. And there was 24% reduction in the death in addition with addition of ribociclib as well. So in the clinical cancer advances, if you see the 2020 American Society of Clinical Oncology, it did the CDK4 inhibitors had demonstrated a survival benefit in premenopausal as well as perimenopausal women, and these patients were aggressive, they had worse survival, but research suggests that these may be biologically different, and the use of hormone receptor or positive anti plus a CDK inhibitor can improve the overall survival in the premenopausal and perimenopausal, and that was in 2020. The Monarch study, that's with the Abemaciclib, it's recently available in India. I think many of us have used it, and it's also at a multi-targeted drug, and that shows that there is a 28 months benefit improvement in the median progression-free survival, okay, and that was significant. And if you see the prognostic characterization of all the patients with abemaciclib, whether you have liver metastasis or your progesterone receptor, there was benefit consistent across the pre-planned subgroup. And the largest improvement was seen with the liver mets. So now how do I choose? You saw the data which covers all the 3 drugs. So a couple of points to be noted. There was no survival, overall survival in a postmenopausal. What we observed was pre and peri. MONALEESA 7 has shown benefit in premenopausal women. Different toxicity profile. How do you choose and how many can afford? Yes, affordability comes because it's a SAARC group of meeting. So we cannot be talking about big drugs. Yes, we do talk about literature, but actually what do we do for an Indian patient? That's what is needed. And that's how the definition of an endocrine resistance grow. What is primary resistance? What is secondary resistance and relapse after 2 years, and the endocrine sensitive responses is that. Now, how do you choose your CDK1 inhibitors in a resistant setting? The overall survival and intent to treat population in MONALEESA 3 and MONARCH 2, and most of the clinical evidence in India is with palbociclib, but yes, we do have ribociclib data coming up and abemaciclib, lot of patients are here. Now, a couple of slides we will skip because these are all been shown a couple of years back, and we have met all with the Palomar 3 and all the others, and there is overall survival definitely, and that was quite significant with the use of fulvestrant and palbociclib. Okay, so the ribociclib data, this is the MONALEESA, again intent to treat progression-free survival. Whether you use it first line or early relapse in a ribociclib, you see the curve separating with a significant p-value. Whether early relapse, second line, first line, it was helpful. So overall survival results of the intent to treat population, though the median overall survival was not reached, but p-value, you see the curve separating at the 42nd month. Patient resembling first line treatment and with second line treatment, yes, there was definite benefit was observed. That's the MONARCH with the abemaciclib, which is more recently available, and it had done the study across different subgroups, different metastatic site, different endocrine status, the different performance status. And if you see the progression-free survival, there was 16.4 compared to 9.3 months. And the overall survival in an interim analysis was difference was around 9.4 months. So, and by metastatic site, as I told you, visceral mets, liver mets, bone mets, or other, that's for the sub-analysis done, whether it's a primary resistance or a secondary resistance. And these were some of the, where the most promising data was received in the liver mets, high grade of the tumor, and when the PR status was negative. Now, let's get into the, now you have seen the data, there's promising data. It's quite difficult at this point of time to say which has a better response rate, which has an overall survival benefit, and which has a progression-free benefit. Looks almost the same. Even the NCCN guidelines and ESMO guidelines does not differentiate to tell use one over the other. But then we are over here for a discussion, and let's see what are the grades of adverse reaction. If you see palbociclib, yes, neutropenia manageable, leukopenia manageable, we are all done it. Anemia, yes, there, infection is there, and a small percentage will have an increase in the QTc interval. Equally, ribociclib do have neutropenia. This is a class effect, neutropenia, leukopenia. There is an enzyme alteration will be present, and also QT interval is there. Abemaciclib has a little different, but remember the abemaciclib has a constant dosing, whereas ribociclib, palbociclib, the gap dosing. And over here, another important thing is diarrhea. Does happen, this is again class effects of these signal transduction inhibitors, and 5% do have a venous thromboembolism. So definitely abemaciclib, less neutropenia. So if you have a patient with a compromised marrow, yes, think of the drug called abemaciclib. If patient has irritable bowel syndrome or anything post-operative for a colon, yes, abemaciclib is not the drug. You can think of other drugs. Take a cardiologist opinion, have an ECG done to see the QT interval, and then plan according to palbociclib or ribociclib. Also, the enzymes are mildly elevated in ribociclib, but not to a bigger extent. So these are minor points which help us to choose. And over a period of time, we have learned how to manage the AE. So an AE or a side effect should not stop us from using the drug. Yes, we know how to manage. There are guidelines over there. And so many of, starting with Palbociclib is the first CDK inhibitor, which almost changed the world to treat patients. And if you see that there is progression-free survival, overall survival, real data is evident, quality of life and safety profile. And not only Palbociclib, all the three drugs have a significant advantage. So if you see the guidelines doesn't differentiate what to use and when. So now I've just got a chart ready for all of you. So Palbociclib, first drug, yes, we have got a lot of evidence. As I told you, we do have real world data. There is an OS benefit in a subgroup of population with prior sensitivity to endocrine therapy. Yes, we know neutropenia is a side effect, but not a major one that will not stop us. And we know how to, because you never get into febrile neutropenia. It's quite a manageable neutropenia. Coming to ribociclib, yes, premenopausal women, we have data, we have the quality of life is improved, OS benefit is there in the Mona Lisa 3, both in first line and second line. And yes, toxicity, neutropenia, but be careful with the cardiac thing. If an ECG shows some abnormality, please consult, because this drug is associated with QTc interval prolongation. Now, abemaciclib. So again, more recently, and it's a constant dosing. Diarrhea is common, so to be avoided in those drugs, those patients who do have irritable bowel syndrome or other issues with colon. It can be used across wide number of patients, and primary resistance, shorter time to recurrence. Yes, it has shown very good results in visceral mets, liver mets, and particularly when you have a progesterone receptor negative disease. It has a maximum overall benefit. And also one important thing is the third generation, these TKIs, they can cross the blood-brain barrier. And that's again something for discussion, whether if you have to prevent the CNS mets, or this can be the drug when a CNS mets takes place. So how do we approach to any of these patients? Having seen the side effect, also think of the cost. I think the first two, Palbociclib, ribociclib, comes with patient assistance program, and I'm sure the Limaye is to become. We don't have generics because patent has not yet expired. And so we need to talk to the company and give. And yes, patients who are eligible, reimbursement sector, private insurance, yes, we should give the benefit after discussing with the patient, but may not be the right choice if they are in a medical college where I practice. So that's the how to go about any AI. You can start as a CDK4 inhibitor. So you can also start in premenopausal, perimenopausal, postmenopausal. That's the data is available. The cancer patients are divided up into visceral mets or visceral crisis, intermediate risks or low risks. Definitely low risks goes without. Intermediate risks, there is data. But in high risks, like with visceral crisis, massive effusion, ascites, multiple bony disease, liver involvement, we might hesitate and think that we don't want for these CDK4 inhibitors to be given. We might start off with chemotherapy, but yes, there is role in high risks. Second line, you can just go on, change to everolimus, exemestane everolimus, look for PI3 kinase, because PI3 kinase mutation comes in once this patient fails the CDK4 inhibitors. You do have a third line. If you have not given, give it in the third line. Fourth and fifth line, we do get back into taxanes and capecitabine, giving an endocrine holiday. Eribulin is also in the list. Just look for some mutation of the BRCA. We have olaparib, talazoparib with the recent data with the brain protection or the brain penetration is available. There is also data in the last ASCO. SABC is the low HER2 status. HER2 may be negative, but look for it because trastuzumab deruxtecan is approved and had shown definite benefit to them. And also the sacituzumab data is also there in the ASCO and the last SABC showing promising results beyond third line. So we have lots to go. Yes, to choose the drug properly. The drug is available with us, and this might last slide show Palbociclib does have overall survival benefit with prior sensitivity to prior endocrine therapy. It can be used across all lines, first line, second line. Ribociclib has shown overall benefit in perimenopausal and premenopausal, improved quality of life, and definite improvement on the progression-free survival in a metastatic setting. Abemaciclib both has overall survival and substantial benefit in primary resistant, and if you have a visceral mets like liver mets. So each CDK4 inhibitor has different toxicity profile. So and if you see the guidelines, they are equal all because they don't say one is it's approved at the same category 1 level. Okay, abemaciclib has advantage also for CNS penetration, maybe in a CNS mets, that may be the drug of choice because of the blood-brain barrier. So, and also remember toxicity profile, neutropenia, leukopenia, anemia remains same. Diarrhea is with abemaciclib, QT interval changes is with ribociclib. So choose judiciously, but depending upon the patient comorbidities, and it is to the population for the maximum benefit. If you want to give the thing, we do also need to discuss about the finances and which is best cost effective should be offered to the patient. And that's all I can say, which Ciclibs to go about with for today's evening in the SAARC meeting. Thank you. If any questions, I'm willing to answer.
Thank you so much, Professor Anita Ramesh. It was indeed a good presentation and extensively covered all the topics about the Ciclibs. Now we do have 3 options, and furthering this debate, we are going to have a debate topic. My first choice is still palbociclib. So Dr. Ramesh has tried to convince us that there are 3 options and pros and cons of all. Now we'll just focus on the first, old is gold. So speaking for the debate is Dr. Rajeev Vijayakumar, and speaking against the debate is Dr. M.V. Chandrakanth. So, and then we'll finish the 2 talks and then again give 2-3 minutes for rebuttal for both of them. So going ahead with that, Dr. Rajeev Vijayakumar, please go ahead. You can unmute yourself, please.
Yeah, I'm now unmuted. Okay, fine.
Yeah, we can see your slides as well.
Yeah, thank you. Thank you, Dr. Professor Anita Ramesh. You actually made our job very easy. At the same time, it should probably be a repeat for all our audience, because this is exactly the same set of slides which I would be presenting, as well as my other colleague, Dr. Chandrakanth, will also be presenting. So what are the points to ponder while choosing a CDK4/6 inhibitor? One, we need to know its efficacy, its ease of administration, whether it's 1 tablet or 2 tablets, 3 tablets, once daily, twice daily. So it helps in improving compliance. Then, of course, about the adverse effects and then the cost. These are the things that you have to keep in mind while choosing a drug. Like we all know, the management of a HER2 negative metastatic breast cancer, if it's non-life threatening, no visceral disease, you start off with a endocrine therapy along with a CDK4/6 inhibitor. It can be used in first line, second line, and third line as well. So I'm just going to showcase to you real world studies with palbociclib. I'm talking for palbociclib as of now. So we have more than 4 years of experience by Indian physicians. We can see here the EBCC and the ASCO 2020 abstracts which were done, showcased we have North India 2 Delhi hospitals, and then after we have from 5 South Indian hospitals. We have enough data about the safety, the tolerability, and the efficacy of palbociclib. So here we're just talking about the real world evidence of palbo in metastatic hormone positive HER2 negative. This is by my good friend Dr. Chaturbhuj Agarwal from RGCI. So here they've analyzed around 188 patients. They found a median PFS of around 20 months. So analysis in Indian patients, including premenopausal women treated with palbo plus endocrine therapy, suggest similar effectiveness to previously published real world evidence and is a standard of care in this population. So again, this is one from my city, Bangalore, where 5 centers were chosen, and this is the data that we have. Almost around 60% of them used in the first line setting. Here the median PFS was not reached. It's yet going up follow-up of 38 months. Here, so basically here again, palbo was resulted in similar efficacy and safety in all our patients as was seen in the Paloma trials. Neutropenia was the most common side effects. So now let's see. Now question is that why should I use only palbociclib? Why am I stuck to that? Is Abema or Ribo better, or is palbo now is it for the folklore and it's not there for anymore? No, palbo, and like Dr. Anita Ramesh told, palbo, Abema, ribociclib, all of them have actually very similar efficacies. The only thing is that we have a large amount of experience with Palbociclib, hence many of us are very, very comfortable. You can see across these are the first line phase 3 trials, the Paloma 2, Monarch 3, Mona Lisa. So for all the three, whatever we have, look at the median duration of follow-up. For Paloma 2, we have almost around 37, 38 months of follow-up, and the rest of them hover between 18 months to 26 months. So the longer you use a drug, the more you are at ease at using it and the more comfortable you are. If you look at the overall survival and the PFS, all of them are very similar. There's not much to choose between them. So now the same thing, use of the checkpoint CDK4/6 inhibitors along with fulvestrant. You have the Paloma 3, you have the Monarch 2 and the Mona Lisa 3. Here, I would like to take your attention to this particular box. One thing in the Paloma trials, if you see, most of the patients have had multiple lines, any number of prior lines of endocrine therapy, at least one set of chemotherapies which they might have taken, may or may not have taken. You can see here that you can see the number of, it's around 33% of them have had previous chemotherapy. And you can see that 35% of the patients are taking it in the second line. That is almost 35%. So if you see, these are all heavily pre-treated set of people. And if you see for Monarch, that is for Abima, and for Ribociclib, none of these patients have had chemotherapy in the past, nor have they had any endocrine therapy in this particular study. So therefore, if you can, it makes it very easy that in the real world, most of our patients at some point in time, we would have had received some amount of chemotherapy, would have had some amount of hormone therapy because of the cost of the drugs. In India and in the SAARC countries, we would generally start, if the patient can afford, of course, the CDK4, else you start with hormone therapy. And then if the patient is able to get the money for it, then we put the patient on a CDK4 inhibitor as well. So now when you look at this, so the both pre and postmenopausal patients have been addressed well, and the PFS is very comparable in both the settings. So now again, this is another real world analysis in the US. There too, along with the propensity score matching, it conjures very well. Again, now let's talk about what Dr. Ramesh told regarding the comparative toxicities. One important thing that we would need to know is that the QTC prolongation was seen around 5 to 7% of patients with Ribociclib. This is seen also in Palbociclib, but the quantity is less. When there was a consortium of physicians in Spain, when they were asked to discuss regarding this, most of them attributed QTC prolongation to Ribociclib. Although in data we see that both of them are almost equal, there's a slight preponderance towards Ribociclib. QTC prolongation is not a class side effect of the abemaciclib. And when we look at the very, very torrential diarrhea and the quality of life is disturbed to a large extent, it goes up to 13 to 15% of patients on abemaciclib. They have very severe diarrhea, which there has been almost discontinuation around 5 to 6% of patients on the trial in the Monarch because of profuse diarrhea. So this is something that, and now that we have in real world evidence amongst our practice, that the diarrhea seems to be very, very, very disturbing, and takes a lot of antidiarrheals to actually settle it off. Of course, leading to dose interruptions as well. So now here we can, I'm just showcasing the monitoring. If you're giving Palbociclib, all you have to do is only CBCs. If you're giving Ribociclib, the initial first 2 cycles, you'll have to monitor the along with the CBs, you'll have to monitor the ECG as well. You'll have to look at the LFTs as well. In the abemaciclib, you have to look at the CBCs and the LFTs all throughout. So this is something that we need to just understand.
So 1 minute left, sir.
Yeah. So now comparison. Now when we see now comparative efficacy of Palbo, Ribo, and Abema for hormone positive metastatic breast cancer. So when this by Foster, Petrelli et al. This is a very good meta-analysis which they did, and finally, what did it find? Based on this, PFS and ORR results are equal in all of them in first line, second line, or third line. The only difference is in toxicity profile. In our country, we've been using Palbo for a very long time, so therefore I would yet stick to Palbociclib. when actually the others don't portend too much of an extra benefit, and we know how to handle the side effects of this particular drug. I'm very happy to use Palbociclib as my first go-to CDK4 inhibitor. Thank you.
Thank you so much, Dr. Rajeev. And now over to Dr. M.V. Chandrakanth for speaking against the motion.
Yeah, I'm just sharing my screen. So I would thank the organizer for providing opportunity, and I would congratulate Rajeev for a very exciting discussion on Palbociclib must be the choice in the present day. So if you ask me today, is Palbociclib still my first choice? And obviously my answer is big no. I said obvious. I think after 10 minutes, everyone will say it's obvious. So I can totally understand Dr. Rajeev's situation. That I know that you're an old comer, you have long-term data, and you want to win, but I can really understand. But the data is not like that. The results are not so. So even if you would like to win, we will see what the results are. So, but after you are defeated, please don't send anyone to shoot me. So to understand Palbo, Ribo, and Abima. So I am a new medical oncologist. I didn't have a car and I wanted to buy a car, and I'm confused whether to buy a Swift Desire or I want to buy a little bit of luxury sedan, or should I go for a premier SUV? So I went with my family to buy which car to buy. So these are the cars that I have. All are attractive. Oh yeah, the Desire is there. Or you have Amaze is there. Oh, these are long term. They're very safe, economical. That is the way to go. Or let me afford a little more or take a better car. Status is important. Or I want to go for off-roading. So which one to choose? Or I should say no. Everybody, all doctors should choose Swift Desire. That is the way to go. So this is what the argument. That was kept, and this is very close to the drug which we had. I'm very sorry for the comparison of drugs with the cars, and I'm not sponsored by any pharma. So you can see the PFS, the cross-trial comparison must not be done, but this is a debate and I have to compare. You can look at the PFS, 2 years, 2.8 years and 2.5 years. Look at the early and rapid response. This is the scoring, 2 out of 5, 4 out of 5 and 5 out of 5. Look at that, 5 out of 5 with the SUV. And then look at the comfort, too much of neutropenia with Palbo and too much of diarrhea because of off-target efficacy. Whereas Ribo, you can look into the comfort and look at the cost per month. I'm totally agree. BPL card, nobody can defeat Palbo. For BPL card holders, drug of choice is Palbociclib. But not for what about non-BPL card who can afford? So 58,000, and look into Abima. 60% patients require dose reduction, and the moment it is half the dose, that becomes the most economical CDK4 45,000 every month. So this is a hard truth that we face in clinical practice. So ground clearance, off-roading, drive duration. So take only for 3 weeks. After 7 days, I go for a holiday. Drug goes for a holiday, but cancer doesn't go for a holiday. Cancer keeps multiplying in those 7 days. So that is not the way. We want a drug that we want a continuous CDK4 inhibition. An intermittent inhibition, cancer will not take a holiday and cancer will increase. And that's the reason why we can see none of these intermittent drugs showing any success in adjuvant trials. And then look into monotherapy. So I just built it as a driver. So monotherapy, only drug that works is Abimaciclib, and none of the other drugs works. So what about difficult to treat brain mets, multiple liver mets, PR negative? This is what we call as off-roading. This is known only for a SUV like Abimaciclib. What about lifespan? I live more. That is what is important. I don't care what the scans are. I don't care what my neutropenia is. I don't care what my QT is. I want to live more. And that is what we have with Ribo and Abima, and we don't have with that. And if I want a fancy car for a marriage function, for example, a perimenopausal lady, we have overall survival data only with ribociclib and not with anyone else. So this is about the PFS data. Yes, I totally agree. Paloma 3 has PFS data. Of course, heavily treated, I have excellent PFS, but even the magnitude of PFS, you can see the number numerically, the PFS is better in Ribo and Abima, but I agree. The hazard ratios are fine. So I totally agree. PFS is similar, whatever you use. Look into the responses. I agree with your argument that yes, the patient selection was different, and that's the reason why my response rates are fine. I agree. I totally agree with this. But what do you want ultimately in a cancer patient? The patient should live long, and the patient should live well. So overall survival and quality of life are the endpoints. What is this PFS endpoint? I don't understand this PFS endpoint in a patient with cancer. So someone called it as a planned flawed study or a profit for sponsorer. So what is the criteria? OS should be the criteria. Look into the Paloma 3 study. Overall survival, you can see it is crossing unity. If you look into intent to treat population, there is no overall survival benefit with Paloma trial. Monarch 2 and Monalisa 3, you can see the hazard ratios 0.7, 0.7. So that is the way you want a drug that makes me live longer, not just cancer better. Again, similar thing I'm saying, that only Abima and Ribo have overall survival benefit, not Palbociclib. So you want a drug where I can say, I can make your scans better, but you're not going to live longer. That is the situation. So the surgery is very successful, but the patient seems to be dying. So but what they have tried to dissect out the Paloma 3 data and say that only in endocrine sensitive I can improve your survival. But if you're endocrine resistant, I will not be able to improve. So it is something like, if you look into the Monarch data, so there, if there is primary endocrine resistant, there the drug seems to be working better. You can look into the hazard ratio, just zeros down to 0.68 versus second is 0.78. So this particular drug works in a difficult to treat population, not in just a sensitive population. And I can totally understand this comparison. If the predator is weak, I want the target to be weak. But if the predator is strong, I don't care which animal I have to kill. So what about monotherapy? We know this famous Bahubali coming up, and is there any data for monotherapy in any of the CDK4? I think we had the Monarch 1, that was the trial where we could see monotherapy with abemaciclib producing responses even in heavily pretreated population. You are saying about Paloma 3 and you are saying about response rate 25%. And look at here, monotherapy in heavily pretreated showing 28% response rates. So that is the way to go. And what about premenopausal women? I was just making the comment. So I'm not saying this is basically MCBS, that is a magnitude of clinical benefit score is 5. And this is the ESMO MCBS score of 5. So if you have a premenopausal lady, the drug to choose is ribociclib, because that is where Monalisa 7 has overall survival data. And that is what is the Bible for all of us. The patient should live long. So the ESMO MCBS is 5 only for ribociclib in pre and perimenopausal women. And this is Monalisa 7. Overall survival data, hazard ratio 0.7, Palbociclib cannot even imagine of this. So then let us speak of off-roading. This is how off-roading all about abemaciclib. So ER positive, PR positive, ER positive, PR negative.
So 1 minute left, sir.
Yeah. So weak hormone receptor negative is a difficult to treat population. And you can see the hazard ratio is becoming much better and better as, and you can look into the brain metastasis. And if you look into, so breast cancer is not a single disease. If I come down to the conclusion, this is the, so after all this discussion, should I, my grandfather has put a banyan tree, should I hang on it? Or should I wait for and go for a different choice? So I think all of you would agree that you're finally fired and you also accept it and you're taking rest. So my opinion finally is bone only diseases where you can offer, or if a patient has a BPL card, I totally agree, you can give, or if the patient has some chemotherapy, I have some evidence with Paloma 3. But otherwise, if it's premenopausal, then ribociclib, and if it's a difficult to treat disease and you want off-roading, and if you want adjuvant, abemaciclib is the way to go. So thank you everyone for patient listening, and back to you organizers.
Excellent presentation, Dr. Chandrakanth. Dr. Rajeev, a couple of comments from your side.
Absolutely. It's a fantastic imagination. Really, it made my day. Thanks, Chandrakanth, on this. Along with this, I would like to say the most tested and the most favorite car on Indian roads is the Dzire and the Maruti Suzuki. The other cars, well, our service stations are also lesser. And then afterwards, well, most of the ads that you see of all these luxury cars and sedan cars are on smooth, beautiful roads. In India, we have a large number of potholes, and for that, Maruti Suzuki works best.
I'll keep watching which car you will buy in life. Thank you. Yeah.
Thank you so much, both of you. Thank you so much.
Thank you.
Excellent discussion and excellent debate. Over to Kashish. Please go ahead.
Thank you so much, sir. Now we will move on to the next session, the academic session 4. It's on breast cancer. Our moderator is Dr. Prasad Narayan, medical oncologist from Bangalore. His panelists are Dr. Reshma Puranik, medical oncologist from Pune, Dr. Bhavish Parikh, medical oncologist from Ahmedabad, Dr. Chandrasekhar Pethe, medical oncologist from Nasik, Dr. Anjana Joel, medical oncologist from Vellore, and Dr. Shefali Sardana, medical oncologist from New Delhi. Over to you, Prasad sir.
Hi, good evening. Am I visible, audible?
Yes, sir, you're visible and audible.
Yeah, and all the panelists are there, right?
Yes, sir, all 5 panelists are there.
Can I have the presentation?
Sure, sir, I'll just share the slide.
Hi, Prasad. Good evening.
Hi, sir. How are you?
Fine, fine.
So
Where is your next marathon?
I just finished one. How are you post-COVID vaccination?
We had taken a vaccination yesterday. No side effect, no pain, no fever, no malaise.
Super.
And today is our marriage anniversary, and my wife also taken today also vaccine.
Wow.
So we both have taken the vaccine.
Very nice, sir. Very nice, sir. Stay safe.
Congrats, Bhavesh. Thank you, Govind Babu, sir.
Hi, sir. You are there, is it?
Yeah,
okay.
yeah.
Good. So, good evening, everybody. It's a pleasure to be in a meeting which goes sharp on time. So, I would also try to stick to the time. And it was an excellent debate. I enjoyed Dr. Chandrakanth's comparison of cars with drugs, actually. And those slides, I'm sure many people are going to take, actually. So, we will go with the panel. Next slide, please. So, I have been asked to take 4 pertinent questions which are from the about breast cancer and discuss it among the panelists. So I thought that we will discuss one about the HER2 positive early breast cancer, about the duration of adjuvant trastuzumab. So the basis of this discussion can be from our own Indian publication, the meta-analysis by Dr. Seema Guli and Dr. Sudeep Gupta, which has recently come, which compared this. I think the timer is not moving, so Kashish is giving me extra time. I don't know. So, which compared the evaluation of 1 year versus the shorter duration of adjuvant trastuzumab among patients with early breast cancer. Next slide, please. So, to put this in perspective, this had 6 randomized controlled trials, almost 11,000 patients, individual patient data meta-analysis, and 5 of these trials actually did not meet the non-inferiority criteria, whatever was the set non-inferiority criteria. But when the meta-analysis is done, there is hardly anything to choose between the 2 comparators. So less than 1 year versus 1 year, there is hardly anything to choose. Next slide, please. So to put this into discussion, I would like Dr. Reshma Puranik and Dr. Bhavesh Parikh to take sides actually, so that we have a kind of a debate plus an interactive discussion. So Dr. Reshma Puranik will justify the short duration trastuzumab, and Dr. Bhavesh Parikh will say that standard is the what we should do. This is in context of the SAARC countries. Dr. Reshma Puranik, please.
Yes, sir. Good evening. I'm going to talk for the short duration of trastuzumab, that is the 6 month. Right. So, like sir has already shown the slides, we have had 6 randomized control trials, out of which 3 trials were for the 9-week versus the 1 year, and 3 were for the 6 month versus the 1 year. So out of all these trials, the Pressphone trial was the one which was able to prove the non-inferiority of the 6 month versus the 1 year. And the population which they included was also almost a population of 4,000 patients. And they established that the 6 month duration was non-inferior to the 1 year. But what is the most important is the meta-analysis that was published by Tata Memorial, and it included all these 6 randomized controlled trials, and this meta-analysis showed that the DFS of 6 months is non-inferior to the 1 year, and they have used an inferiority margin cutoff of 1.3. So that is where they were able to prove. But in the subgroup analysis of this meta-analysis, the subset which was ER positive and node negative, this was the one in which the DFS was, the comparison DFS was hardly, there was hardly any difference between the 2. So we could easily offer the 6 month duration to this population. And but to conclude from this meta-analysis, that I would suggest still offer the 6 month duration to those patients definitely which is the clinically low risk disease, that is the ER positive and the node negative. So for this group of patients, especially in the SAARC countries, or especially in our population, which we have a little economically challenged population, definitely in a clinically low risk disease, we can offer this adjuvant trastuzumab, because the DFS, we are having as much of a DFS as much we have with 1 year, as well as in those patients in which we feel that the cardiac risk is high. So with those with cardiac comorbidities also we can give them. And in the third scenario, we have to be a little judgmental. In those patients with high risk, but who have economic constraints, we can still give them a benefit of this 6 months, because the maximum benefit occurs in the first 6 months of the duration. So for them also, we may offer this therapy. So that is why I support the short duration of trastuzumab.
Thanks. Points well taken. Bhavesh, sir.
So again, as Resma rightly told, it is word is non-inferior. And again, all this thing is maybe or likely that we can take. Again, as we all SAARC countries, we are telling that we are poor countries or there is a real, but with so many generic trastuzumab available with us, we had started like before 10 years with whatever the cost and today's cost. I think if we put a cost as a bar or different part, then definitely 1 year is the recommendation. And there are so many trials in so many years. It was the standard, it was the suited, or it has been practices. The first trial also has been started with 1 year trastuzumab. So I am clearly telling that whatever the problem at present also, and again in Pradhan Mantri Yojana, in my Yojana also, we can definitely have 1 year trastuzumab with whatever the best DFS. And as you also rightly mentioned this again, from Seema Gulia and Sudeep Gupta's trial, the both if DFS and OS is the almost same, then definitely we should stick for the 1 year trastuzumab. Only point is that some of the times there may be a cardiotoxicity. So as Resma rightly told, that if a patient definitely had some cardiac problem, so apart from that comorbid illness, if we really want to target HER or anti-HER, we should stick to 1 year trastuzumab, not for a short duration. Thanks, Prasad.
Thanks, sir. So next slide. So I think both of them have put their points, and everything is right actually. So that is what oncology is all about. So definitely the short duration anti-HER2 therapy is non-inferior in a large group of patients. Now, who are these large group of patients? How are we going to identify them? I put this question to Dr. Sudeep Gupta himself in the last one of the sessions, and maybe we will never get this answer, because I don't think that, or this question is not going to be addressed any further. And these trials which have been put into the meta-analysis also had a varied set of patients from 9 weeks to 6 months. So 6 months seems to be an acceptable option for such patients, and it's unlikely we will get a randomized trial. And all the new studies, or this comes under the broad group of de-escalation. So all the new studies, what are we de-escalating? It is adding hormone therapy, adding a CDK4/6 inhibitor, or de-escalating chemotherapy, going away from anthracyclines in this regard. And now we are going into dual HER2 inhibition. So HER2 positive patients itself will become a spectrum of disease. And from an Indian scenario, and as our panelists rightly put, I think a short duration can be considered for a group of patients. But as of now, we cannot select a patient for that just based on what evidence we have. So next slide. We'll move on to the next point, and which was discussed in detail today, including the debate and the presentation by Dr. Anita Ramesh. So we have these CDK4/6 inhibitors which have come and established, changed the way we treat hormone positive metastatic breast cancer. Our confidence in treating patients with hormone therapy has definitely increased. And they are all similar, though Chandrakanth was able to show us a difference among all of them. But in terms of the hazard ratios, it's almost difficult to differentiate them. In first line, if you take all of them have proven a benefit in the PFS and similar response rates, which is better than the single agent hormone therapy. So next slide, please. There is some benefit of overall survival, which was shown in the previous speakers as well, in the MONALEESA 7. Next slide, please. And Paloma 3 actually showed a non-significant trend towards improved overall survival. That is with the fulvestrant and palbociclib. Next slide, please. So we will take this question that in the setting of our country, our SAARC countries, should we consider CDK4/6 inhibition? Specifically, this is in the first line. So Dr. Chandrasekhar and Dr. Anjana Joel will take this up, and Dr. Chandrasekhar will go first. He will speak for first-line CDK4/6 inhibitors, which is with his reasoning for the same. Dr. Chandrasekhar, please.
Thank you so much, Dr. Prasad. Now, this is a wonderful way that you have arranged things. Point number one, in this question, it
makes my job easier. Yeah, that's right.
Absolutely, absolutely. Now, I can see two hidden questions in your presentation here. Should CDK4/6 inhibitors be included in first-line therapy? And should it be essential for SAARC countries? Now, I can see these two questions here.
Right.
Now, let me answer the first question. There is no debate about it. I don't know why we are debating about addition of CDK4/6 inhibitors. Let me take back to an era when I was doing my DM, when we had only, I think, two drugs, letrozole, anastrozole. Then exemestane came in. We did not know how to use fulvestrant, so it was said that letrozole/anastrozole is better than fulvestrant. Now we have come into an era when we say that fulvestrant is a better drug as compared to anastrozole/letrozole. Now, with the additional advantage of fulvestrant, we still know that most of the patients progress within, say, 10 months, 12 months, and then we go on to use chemotherapy. We did not have anything to use. Everolimus at that point in time was very costly and very poorly tolerated drug. So we landed up actually with chemotherapy. Now with this particular advantage, now if I have one more drug into my armamentarium, which is a CDK4/6 inhibitor, we already have three drugs on the line. So meaning that we have got excellent things going on into prolongation of whatever advantage has offered to me by the simple drugs like letrozole or anastrozole or fulvestrant. So if I want to have a patient sitting in front of me, say an 80-year-old lady who is absolutely bent on not taking chemotherapy, and I want to give her the best possible care with a drug which is relatively non-toxic. If you look at the data which was presented to us by Dr. Chandrakanth, we see that the PFS, I think, has varied. The risk reduction has varied from between 40 to 55%. Such a phenomenal improvement in the risk of progression with a simple drug which has relatively less side effects. I'm literally bombarded that I definitely should be using this drug. Now add to it that there are two more trials which tell me that the patient not only live a better disease-free life, they also go on to live longer. Now this is something which is unimaginable in a metastatic CA breast. Added to it, the third advantage is that the patient's time to taking chemotherapy also is prolonged. Add to it the fourth advantage that hormone therapy has been would take a little more time to work. Now add to it that these drugs not only help in improvement in the lifespan, a better life with a better quality of life, they also hasten the results. Meaning that a patient who has probably borderline LFTs, which in bygone days I would have said that these patients qualifies for chemotherapy. Now I can put these patients on these simple drugs. Toxicity, highly well tolerated drugs. Neutropenia, I have not seen a single patient landed up into neutropenic fever. Yes, we do have neutropenias, but I do not think it is much of a problem. You just stop the drug, slightly dose reduce in the next cycle, and then we have got a phenomenal improvement in overall survival. So I don't think that there is anything to debate about it. About SAARC countries, now we think that we are poor. We are not poor. I think most of the billionaires in the world reside in India. Meaning that, yes, it is a notion that our patients do not afford it. But then as Dr. Chandrakanth and maybe the company guys have pointed out to us, a BPL card holder goes on to receive free Palbociclib, nothing like that. The companies have been very forethought in telling me that if my patient receives, say, an XYZ drug for XYZ period of time, rest whatever we have will be free of charge for the patient's lifespan. Meaning that I need not worry whether I'm residing in a European country or in SAARC.
I think we'll have to go to Dr. Anjana because
I finished.
Right. Thanks.
Thanks, Dr. Prasad.
Yeah.
So now points in favor of later generation CDK4/6 are one, numerically, so everybody had all options had a comparable hazard ratio. Now, when you look at a numerical prolongation of first-line PFS, probably abemaciclib had the longest. Now, if you look at numerical response rates, again, abemaciclib probably had the highest response rates. Now, is this, and of course, we know that in terms of dose reduction, abemaciclib and ribociclib are much more easier to dose reduce. Ribociclib is 200 mg tablets, so it is much more easier to dose reduce that. And of course, abemaciclib also, we know that even in the trial, 60% of patients, like how Chandrakanth very beautifully illustrated, that they needed a dose reduction. So because of that, I mean, I agree with the cost part of it. And even if, we have a patient who may pay, we can go ahead and, abemaciclib may just about work out to be cost effective. The other advantage of abemaciclib is it probably enters the brain, but that is probably relevant in only a very small subset of patients with ER-positive breast cancer in the first line. Now, why should you use it upfront? Well, I'm really unsure about what proportion of our Indian patients, or I would say maybe SAARC patients, go on to second line or third line treatments in metastatic, various metastatic breast cancer or even other solid organs. So those would be some points in favor of using abemaciclib or the later generation of CDK4/6 upfront. And a word about the toxicities. Now, a lot is talked about the toxicity of abemaciclib, but I guess it is the same thing with things like ipilimumab and so on. But it's just that I think we will also be better with handling the toxicity the more we use it. Okay, so I mean, that's all I have to say.
So both of you almost favored using them in first line. So next slide, please. So basically that is because there is a definite improvement in response rate and PFS in all subsets. And
hello.
Yeah.
Oh, thank you.
Improvement in overall survival is modest in first line, and the reasons could be many actually: trial design, crossovers, numbers. So I think overall survival, if we keep that in mind as the reason not to choose them in first line, I think we are not doing a great job. And there are a subset of patients who do well with single agent AI or fulvestrant, and it is difficult to find out who are these patients, because regardless of whether the patient has got only bone metastasis or limited metastasis, they all did well with the addition of CDK4/6 inhibitors in the first line. So what we can take away is that CDK4/6 inhibition in first line is almost there to stay, and is the standard of care at this point of time, unless there is an issue. And overall, the role of chemotherapy in this population has become extremely less. Next slide. So we'll take up the next point. I recently had a patient whom I had suggested chemotherapy in early breast cancer, triple negative, where I suggested dose dense AC followed by paclitaxel, and they got a second opinion from one of the famous online platforms, and they said that this is not the standard of care and the patient should get carboplatin based chemotherapy in the first line early breast cancer. So I thought this is something which we should discuss, whether about the escalation strategies in all triple negative breast cancers. Dose dense chemotherapy, definitely we are giving it for most of the breast cancers with growth factors coming, that has become easy. Addition of carboplatin and cisplatin in the first line as a standard of care, maintaining with capecitabine. Also talking about PARP inhibitors and immunotherapy, like getting a BRCA testing done, getting the PD-L1 score done in early breast cancer, and talking about this. So next slide, please. This is just to show that addition of platinum actually has shown in multiple trials to augment a pathological CR in triple negative breast cancer. And that is the basis, that might be the basis for that second opinion which I had seen. Next slide. So we will have Dr. Shefali Sardana, who will speak for escalation strategies. That is, she will say that all the patients with triple negative needs an escalation strategy from our usual chemotherapy, and Dr. Reshma Puranik will say against it. So Dr. Shefali, please.
Yeah, good evening, everyone. So, and thank you so much, sir. So, putting the panel in such a way with a wonderful discussion is something new to me, actually. So, but taking it forward, so as we know that triple negative breast cancer have a high risk of relapse even in the early stages to the tune of 20 to 40%. And when the world is talking about de-escalation and moving towards targets and all things, so I mean, we understand that there is an unmet need in triple negative. That is why we are looking for all these strategies.
Right.
So there is something behind this, deciding the strategies. So these strategies can be in the form of either, adding of the new drugs like platinums, like capecitabine, be it immunotherapy or PARP inhibitors, or playing with the dose like 6 months versus 1 year of capecitabine, or other way around, or making it dose dense type of chemotherapy. So of course, once we talk of, you put forward 4 points. So if we talk of dose dense chemotherapy, I think there is no debate in TNBC. We should go ahead with dose dense. That is the way forward, even in spite of so many ifs and buts and here and there trials. Adriamycin is still the drug which cannot be replaced altogether. So we all agree on this. Now coming to add-on of platinums. So 2, 3, 4 trials, meta-analysis have all shown that of course there is an add-on advantage of adding platinums in the form of PCR, and various studies have shown that PCR is a surrogate marker for improvement in prognosis, be it the disease-free survival, relapse-free survival, or overall survival. However, having said that, there is still no concrete evidence to say that, okay, platinums are standard of care, because we understand these trials had several limitations. So
Right.
these limitations could be in the form of none of these trials was designed to see actually the overall survival benefit in the first endpoint. So they were all designed either for the purpose of seeing a PCR or for the purpose of, say, could we replace anthracyclines in few of the trials. So I would say, so design is the basic limitation of these trials to see for the overall survival. And second, we understand the adverse effects, and some trials did not use the standard of line, dose dense was missing somewhere, so cannot be compared or extrapolated in terms of that. Now, if we come to capecitabine trials, so they have again shown that there is a DFS and OS benefit, be it the 6 months, be it the 1 year. And again, we see the limitations that, okay, there were hormone positive patients. In some trials, TNBC subset was low. In some trials, there was low recurrence patients already. So there are again certain limitations. So now if we come to the immunotherapy and the targeted therapy like PARP inhibitor trials, we understand that in our setting, affording such a, these kind of therapies is a constraint, and in lack of a appropriate biomarker, again, there is a limitation. So I would say the crux is not to avoid the addition or the escalation strategies, but to selectively choose our patients.
Sure.
So, various studies have shown that TILS can be a biomarker, family history can be a biomarker, BRCA-NEST can be a biomarker. So I think younger patients having all these high-risk factors should receive some kind of escalation strategies, but with a pinch of salt that all patients, or one size does not fit all, is true for TNBCs also. That is my take on that.
Sure. So, Dr. Reshma, what do you have to say against this escalation strategies?
So when we are looking at escalating all these strategies in TNBC, what are we looking at? We are not looking at a small benefit in PFS here and there. We're looking at somewhere like an overall survival benefit. We want to increase the survival and give some benefit to the patient when we are advising all these strategies. So coming to first dose dense, I agree it is there in the guidelines. We are able to prove a benefit, but have we all actually practically being able to give? Because I find many of my patients are not really tolerating it, because we try to follow a dose dense schedule, but ultimately they land up in 3 weekly. Even the younger, fitter patients many times land up in neutropenias, and your schedule really doesn't get followed. So many times we end up giving a 3 weekly schedule. So I feel toxicities and following the schedule is really a practical matter of concern in the dose dense. And even that meta-analysis has shown basically a DFS benefit. The OS benefit is not really that convincing for the dose dense schedule also. So secondly, coming to adding the platinum agent, we are all very much into the adding the platinum agent, considering neoadjuvant, adjuvant, or in the metastatic setting. Neoadjuvant, I agree, it has increased the CR rate, but it has not translated into any of the DFS or OS benefit. In the adjuvant setting, some trials have proven some advantage of adding platinum, some trials no benefit. So there's a lot of discrepancies. So as of now, platinum has not yet come into any guideline because we don't have any consistent data for adding platinum.
Sure.
Considering the capecitabine maintenance, I agree. For this, I would not say anything against this because the Createx trial has proven a definite benefit. But I would like to emphasize that there is a very specific subset that only those patients in TNBC whom you have offered a neoadjuvant, in whom a residual disease is there, only these patients you are able to give. So there is a very small subset of patients that you may be able to offer the capecitabine. And coming to immunotherapy, immunotherapy has been tried in the metastatic setting. We have atezolizumab, nab-paclitaxel, as well as we have data for pembrolizumab. But if you see, the PFS benefit is really very small. It's just 2 months, and the OS benefit is not statistically significant. So where are we looking at the cost-effective way out of this? So I'm just offering the patient a 2-month benefit and look at the cost. The cost is so much. So are we looking at something which is cost-effective? So immunotherapy needs more trials. I think we have it in metastatic, but we need more trials in the neoadjuvant adjuvant setting. And PARP inhibitors, okay, they are now in the guidelines for patients who are treated with multiple chemotherapy lines and all. So PARP inhibitors definitely can be offered to the BRCA patients.
Only one comment, Prasad, for RESMA. There are so many patients, like as RESMA told, that small subset. But I think most of our triple negative neoadjuvant, when we give chemotherapy, very few have no residual disease. Most of the patients clinically have residual disease.
Yes,
sir. I want to say only in this subset we can offer.
Yeah, that's why we require capecitabine maintenance. That's only a small point.
I agree with the capacity.
Next slide, I think that is next slide. This is very well discussed in the panel. Routine use of platinum hasn't improved the overall survival. So it is not that it can be recommended for everybody, but it is sometimes used. Correlation of PAT-CR with survival hasn't been consistent. That is the fact of matter. But that is the best hard endpoint which we can look at. And present data doesn't support any PARP inhibition immunotherapy in early stage disease. And definitely, there is nothing much against to say about capecitabine maintenance in patients with residual disease. Next slide, and that is the last point of discussion. So I thought this is something which can be discussed in a SAARC country point of view. And this was one article which I read with great interest, and I will read this is published in South Asian Journal of Cancer. And when Dr. Badwe and Dr. Sudeep Gupta write something like this, then it definitely has got a lot of implications. So this was after one of the larger trials on screening mammogram, which was published in NEJM. This was like a commentary on that. And it is said that the population-based randomized studies comparing screening has indeed proven the downstaging effect, but the effect on mortality is more complex and uncertain because of so many reasons. Because there is no unequivocal evidence of benefit in younger than 50. In more than 50, definitely there is a decrease in breast cancer mortality, but there is no all-cause mortality thing. And most interesting thing is that these patients will get a certainty of a surgeon's knife and the overwhelming odds at the receiving end of other multidisciplinary handymen like radiotherapists and chemotherapists being the most prominent, and the psychological impact. Next slide, please. So there is nothing much to discuss on this. We will have Dr. Bhavesh Parikh and Dr. Chandrasekhar Pete to speak on their thoughts on this. So Dr. Bhavesh Parikh sir, do you think that we should do screening mammography in our country? And if yes, why? And Dr. Chandrasekhar, your thoughts against it.
First of all, congratulations again, Prasad. And as again in this debate, you had selected both GCRians guys. Also in my first debate, also both the GCRians guys. So I have to tell that definitely screening mammography is useful. But screening mammography, what subset of the patient? We had our own practical issues, dense mammogram, the large breast. So technicians, the only mammogram or some of they are doing MRI breast. So I personally, my conclusion is, I am definitely interested to do the screening mammography in a high-risk patient, in a proper counsel patient, with a proper reporting of the mammogram. That is definitely will decrease the mortality rate or the early detection of the breast cancer. Over to Chandrasekhar Pete.
डॉक्टर प्रसाद ये ठीक नहीं किया, बाद में भावेश भाई मुझे बहुत मारने वाले हैं. Anyway, sir made my job very simple. He talked of multiple things that we should be practicing in our setup. 70% of Indian population stays in villages. In villages, we do not have cancer specialists, leave alone the mammogram. So even if I want to do a mammography, where am I going to get the machine from? Second, even if I get a machine from, say, an XYZ society is sponsoring a van for me, they take 15 days to report a mammogram. And then after those 15 days, most of the patients, around 30% patients, will tend to have an overall diagnosis. Now look at the scenario. It is difficult to convince a patient in a rural setting to come to my van to get a mammogram done, and then convince them to get a mammogram done, and then I don't get a report in my hand. Meaning that availability is a big issue in our setting. Second, the paper itself says that most of the patients in US who were diagnosed to have breast cancer ultimately did not improve the mortality at all. So what am I going to achieve by treating cancer? I want the patient to live longer, and I want to have the patient to live better. Now both these two primary things did not get satisfied in a general population. The same thing happened with lung cancer. We screened, no improvement in mortality at all. Then we came down to a select population wherein we need to screen only the high risk cases. So now the entire crux of matter here is that in say Western population, incidence of breast cancer 1 in 8. In rural India, the incidence of breast cancer is 1 in 120, meaning that to get one patient with breast cancer, I have to screen 120 patients. There is no cost benefit ratio in this particular. Let the patient become symptomatic, come to me. I lose nothing because the trial itself now has proven my point of view that the patient will not live longer even if I diagnose them earlier. This is something which goes against whatever we thought. Earlier diagnosis of cancer, better the cure rates. Unfortunately, we have not been able to prove it. Added to that, the problems of rural India, added to that, the problems of accessibility to mammography. I think this paper, I'm happy in telling my patients, even if you don't come early to me, I'm still fine with that. Over to you, Prasad, sir.
Next slide. So that was good to discuss. But definitely, this is what both the panelists said, that there is a role in high-risk population. There is a definite role in early detection. Now, the impact, if we want to say that I will accept this as a universal program only if the overall breast cancer specific mortality will increase, then it is debatable. And we might not have an answer. How long we will wait to get these answers? If we have not proven it in 3 decades or 4 decades, the answers are not going to come. So definitely this will remain like this. Next slide, please. So I think that's all I have from the panel, and there is 23 seconds which is given back to the organizers. Thank you.
At the end of it, one small comment. Bhavesh bhai, tame jo bolo cho tame.
Thank you so much.
Thank you,
Kashish,
and thank you, Amit Bhatt and Govind Babu. Wonderful experience. Thank you, Amit.
Thank you so much. And Prasad, this is a very novel way of panel discussion. Instead of the in-ring umpire, you are the third umpire now.
Right.
I guess a lot of people are going to copy this third umpire moderation now.
Correct.
Excellent panel discussion. We go on to the next session. Dr. Kashish, please go. Take over.
Thank you so much, sir. We'll now move on to the debate. The topic for the debate is treatment for asymptomatic brain mets in patient with oncogene addicted lung cancer. Our first debater is Dr. Indu Bansal, radiation oncologist from Gurugram, and she's going to talk for RT. Over to you, ma'am.
Thank you. We will have Dr. Anju Bansal speaking, then Dr. Ullas Batra, and then Shyam Agarwal, sir, for the final comments about the debate. Please go ahead, madam.
Can I start sharing my screen now?
Yes, ma'am. Please go ahead.
So, good evening, everyone. My talk is going to flow on how radiation definitely helps in treatment of asymptomatic brain metastasis in a patient with oncogene-addicted lung cancer. So I know that Ullas is not going to agree to this, but let me prove it. So we know that 50% of patients with non-small cell lung cancer develop brain metastasis throughout the disease course, and brain is the only site of metastasis in 51% of the cases. And in patients with EGFR mutation, the incidence of brain metastasis at diagnosis is 25%, But after standard of care TKI, the CNS progression is 20%. Also, same is the case with ALK mutation. In pre-treated cases, the incidence of brain metastasis is to the tune of 45 to 70%. KRAS mutation is seen in 30%, but we don't have any approved targeted therapies available. So this is something which you all as medical oncologists know better than me, that crizotinib crizotinib for ALK positive tumors has shown a very good response rate to the tune of 10.2 months. And then we have a number of other drugs like ceritinib, brigatinib, alectinib, luratinib. And in fact, because of CNS penetration, ceritinib and alectinib have also been come in the first line. So, and there are some good intracranial responses. So, what are the treatment? I will focus more on EGFR mutation because that is what we see more commonly. So, we know that because of poor permeability of the blood-brain barrier, chemotherapy has shown very poor responses to the tune of 4 to 6 months. Whole brain radiation shows overall response rate of 4.5 to 6 months. But because of the risk of neurocognitive dysfunction, many people fear using WBRT, but we have options how it can be used judiciously. For TKIs, geftinib, erlotinib, afatinib, they show a response rate of 60 to 80%, but the progression-free survival in brain is to the tune of 10 months. And osimertinib definitely shows a better intracranial control. Sorry. Just a minute. It shows a better control. If we talk about ALK inhibitors, then alectinib, ceritinib, and luratinib and brigatinib, they are better for intracranial control. Now, what else we can do? That is, we can use radiation as SRS, or we can use a combination of all of these. So how to decide treatment for oncogene-edited non-small cell lung cancer? The goals are to prolong survival, optimization of control, and maintenance of neurocognitive function. And endpoints are local response, quality of life, time to brain progression, toxicity, and of course, overall survival. So let us discuss why TKIs alone are not enough, because only 2% of small molecule drugs are able to effectively cross the blood-brain barrier. Reason number 2, we know that most common EGFR mutations are exon 19 and exon 21 L858R point mutation, and all these drugs, they act better for exon 19. And we have 15% of EGFR mutations which are rare, and the efficacy of TKIs is not known, but still we keep on using them for all patients with CNS metastasis. So if we see this, whether we talk about first generation, second generation, or even osimertinib, all these drugs show a better response for exon 19, but for L858, we need to use radiation, otherwise the responses are not same. So and also the responses are not sustained. Reason number 4, if we see all these studies, see the patient numbers which have been used, 17, 8, 41, and in spite of that, we have been using all these drugs. And we definitely believe that osimertinib is doing wonders, and we see that from AURA and FLORA trials, but is the small and retrospective data alone sufficient to use only TKIs? Number 5, we injudiciously use erlotinib. But does my dear friend know that if there are some poor prognostic factors on MR as tumor necrosis, rim enhancement, tumor location in frontal lobe or putamen or cerebellum? And in the absence of such features, if patient is on erlotinib, he may not respond. So we have to start radiation early or change the TKI. Reason number 5, we know that all of these drugs, they lead to a rapid resistance to TKI, and we all know about T790M mutation. And even patients who are on osimertinib, they develop a number of other mutations as EGFR resistance, BRAF, HER2, and in fact 10 to 14% patients can have a small cell transformation. So do we want that to happen to our patients by not using radiation? Reason number 8, we have only 3 or 4 available and effective TKIs, and even osimertinib everyone can't afford. So my advice to you, my dear friend, is that these TKIs also have their toxicities, and in fact, posterior reversible encephalopathy syndrome can be seen with use of these TKIs, which can be confused with brain metastasis. So please use your TKI judiciously. जरा संभाल के रखिए दोस्त ने, ये TKI है, radiation नहीं कि बार-बार use हो जाएगी. Now, reason number 9, there is around 16 to 30% discordance rate between primary tumor and metastasis. And in fact, rebiopsy after TKI failure shows that only 17% of CNS lesions were T790 mutated. And we expect osimertinib to work in all the patients. So are we justified in treating brain metastasis as per the mutation status at time of diagnosis? Reason number 9. we need all the metastases are not same. So the mutations at the primary, in the lung, in the brain, in the liver, they are all different. There is not just intratumoral heterogeneity, intermetastatic heterogeneity, intrametastatic heterogeneity, as well as interpatient heterogeneity. So how can a single drug work at each and every metastatic site? Reason number 10. If we evaluate the natural growth rate of metastatic tumors, then you would be surprised to know that for lung metastasis, 1.14% of the total volumes are doubled. And the average growth velocity for lung lesions is 0.04 centimeter cube per day. And in fact, the cystic tumors grow even faster. So only TKI are not going to be sufficient. Number 11, that we all measure the responses which are measurable, but leptomeningeal metastasis, dural attachment, cystic metastasis, they are not measurable, and we may miss the chance of treating these patients early. So what are the problems if you start with TKI and whole RT until brain progression? One is that we are not doing serial MRIs. So in the intervening period, there could be dramatic major brain progression, severe neurological symptoms may develop, non-target lesions may progress, and most important is that the window period of SRS may be missed. And in fact, the cystic metastasis may enlarge and lead to death from mass effect and subsequent brain herniation. So the Ramban solution for all these problems is incorporate radiation early, either with SRS alone or in combination with radiation or with TKIs. So I am going to tell you how to use all these combinations. Solution number, so I talked about whole brain radiation. So we all feared neurocognitive deficit, but let me tell you, my dear friend, that now we are using hippocampal avoidance as well as memantine in patients with whole brain radiation, and it does not lead to deterioration of neurocognitive function. So it can be judiciously used if there are multiple number of brain metastases. So even if asymptomatic. So what are the advantages of SRS? There is no neurological sequelae of WBRT. Single sitting, ideal for less than a 3 centimeter lesion, can be used for any site, whether frontal, cerebellum, can be used as a boost for surgical cavity. It can be used for small cystic lesions. Repeat SRS is possible multiple times, and we can treat even up to 10 lesions if total is less than 15 ml. It can be integrated safely with TKI, BEV, or immuno. It improves response rate as compared to only TKI, and it helps in delaying use of subsequent TKIs. Response rate is 80 to 90%, lasts for 11 to 12 months. It can be used with any TKI and is not mutation specific even for rare mutations. So what are the solutions? So we know that SRS can be used alone, and even we use up to 1 to 3 brain metastasis, overall survival is same whether we use SRS alone or we use it with whole brain radiation. So the best solution, my dear friend, is marry TKI with RT, because TKI would help in inhibiting the RT-induced DNA damage repair. RT will increase the EGFR expression, decrease EGFR resistance, damage the blood-brain barrier, facilitating penetration of TKI in CNS. So my friend, I'm helping you let your drugs work better. So don't keep on bombarding your patient with just with TKI, but incorporate SRS early so that your medicine's drug works better. And metastasis directed therapy helps in continuation of same TKI and extracranial disease control after control of CNS disease with SRS or SPRT. One more advantage is that when we use high dose SRS, then it leads to abscopal effect because of it leads to improved, promotes immune response. So it can lead to response outside the treated field also. So what are the evidences? So this is one evidence which showed that if you give SRS first, then SRS group had a better overall survival, 58.4 months versus 19.4 months in patients where upfront EGFR was used. If this evidence is not enough, so let me give you another evidence. So this evidence shows, this is a recent publication just published 2-3 days back, which shows that if you give metastasis-directed stereotactic radiotherapy in patients progressing on TKI, so after 1 year, 58% of patients of oligoprogressive disease and 39% of polyprogressive patients remained on the same TKI. And even if second progression happened after metastatic directed therapy, then these lesions were oligometastatic in 60% of the patients where we could still tackle them with SRS. So metastasis directed therapy helps not just in overall survival, progression-free survival, but also time to systemic therapy change is longer in such situations. Evidence number 5. So this is a recent publication published by JCO by ESCO, which has clearly shown that if you use upfront SRS versus upfront EGFR plus TKI, in TKI naive patients, it's a retrospective institutional analysis, then it leads to improvement in overall survival as well. And it is useful in all the GPA classes, whether it is 0 to 2.2 to 3.5 or 0 to 1.5. So it is molecularly tested group where it demonstrates the use of upfront EGFR and TKI, and deferral of radiotherapy is associated with inferior overall survival. So SRS first is a better option. Now, what more evidence, my friend, do you need when your own favorite drug, that is osimertinib, is being compared and used with patients with 1 to 10 brain metastasis, where SRS is used for macrometastasis and osimertinib for micrometastasis to prevent whole brain radiation. So my approach would be use metastasis directed therapy, which is more useful rather than switching to another TKI. There is reduced efficacy of subsequent lines of therapy, which leads to distant progression. So better to use MDT. It obtains good result with limited toxicity in primary oligometastatic situation. And whole genomic sequencing studies have shown through parallel evolution, there are subpopulation of metastatic clones which can metastasize themselves. So if we target the metastasis early, we can prevent that. And it resulted in good overall survival in oligoprogressive disease and allowed continuation of systemic therapy within the first year. So this is my take. So how to use it judiciously? If it's an asymptomatic patient, TKI naive, better is to use, and it's a single lesion, then maybe we can use, and there is no extracranial disease, we can use SRS and continue the same TKI, say geftinib or erlotinib if the person can't afford osimertinib. If there are 1 to 5 lesions, extracranial disease is controlled, use SRS or 1 or 2 bigger ones and continue the same TKI. If there are multiple lesions, use SRS or 1 to 2 if no extracranial disease, and you can continue the same TKI. But if after 1 or 2 lesions, new lesions develop, you can still add SRS and continue your same TKI. But if multiple lesions, extensive extracranial disease, you can use whole brain radiation. But of course, if a patient has progressed on TKI, then also we check for T790M mutation. If it is positive, we can use osimertinib. And if there are multiple lesions, extensive extracranial disease, if needed, we can use whole brain radiation, but it is better to delay it as much as possible. If patient is resistant to osimertinib, then of course we have to add on chemotherapy. So my friend, TKI alone or radiation alone will not help in such patients. What we have to do is we have to integrate and understand the timing and modality of brain radiotherapy should be such that we can individualize it on an individual basis and with a multidisciplinary approach, even in because symptomatic patients are usually excluded from clinical trials. So it is better to use in a proper sequence so that we can achieve the optimum results. Thank you.
Thank you so much, ma'am. Now I'd like to request Dr. Ullas Batram, medical oncologist from New Delhi, who is our second debater, and he's going to talk for TKIs. Over to you, sir. Sorry.
Thank you. And Dr. Indu, I must compliment you. I'm 100% sure in theory you would have got 100 में से 200 number मिले होंगे. You know, I mean, I'm reminded of a story. I was asked to, talk about a cow. I didn't know a cow, and it was 35 marks question. So what I did was they told me you leave the cow in the village. They did go to one room, you talk about that. They go to another room, you talk about that, but you don't talk about the cow. What you did in the last 8 minutes was spoke about everything except for the debate. Now I will tell you what the debate is all about. So my first thoughts when I saw brain mets and medical oncology, radiation oncology, a debate against radiation oncologists with brain mets, it went to Kaba, Australian pace attack, radiation oncologists with WBRT, SBRT, and it looked like the menacing ones. And I was a poor medical oncologist like Ajinkya Rahane, which came over there, medical oncologist treating brain metastasis. And I thought, okay, let's see what exactly we are going to do. So why are we even debating this? We are debating this
Because 30 years back, the treatment of non-small cell lung cancer was only chemotherapy. There was no histology or molecularly directed therapies, and treatment of stage 4 non-small cell lung cancer was only whole brain RT, which was bad. Dr. Indu told there's a blood-brain barrier, and that is why radiation oncology is used to rule the roast. But survival was only 2 to 3 months, and the neurocognitive decline was sufficient. Then came the SRS, and I will give it to you. SRS, you know, the latest things in the radiation oncologist armamentarium, as we will do SRS. And look at these trials of SRS in brain metastasis. Something which Dr. Indu did not show. The CNS disease control is to the tune of 50 to 60% only for those particular lesions, not for the entire brain. Please remember. So what happens when you give radiation and when you give SRS to the lesions and then the progresses? So it treats the lesion, but what about controlling the rest of the brain parenchyma, which is the micromets in the brain? You don't know anything about that. It's got only a 70% disease control rate. The number of lesions that can be treated are very, very less. The volume of the disease, are we clear? We don't know. What exactly are we treating? Are we treating a report or the patient? Remember, the patient is absolutely asymptomatic, Dr. Indu. What are you treating? So I would like to remind you about, listen to your patient. He's telling you the diagnosis. It's a non-small cell lung cancer, asymptomatic. Treat the patient, not the disease, not the report. So what about the first and second generation TKIs? And Dr. Indu, you said 2%? Look at the data over here. 85%, 56%, even with erlotinib and gefitinib, we have got the disease control rate over here. Please. So the result is same, but no, it's different. What about the data of RT and first generation TKIs? I've got 4 randomized or retrospective studies, which have basically said that there is no difference in the OS between upfront RT group and the deferral group. Also, what about the EGFR TKIs plus whole brain RT along with the only TKIs? Please look at it. The addition of WBRT to EGFR TKIs did not have any survival benefit. Again, look at the radiotherapy for the asymptomatic brain mets in patients with EGFR. Look at the word debate, asymptomatic. Look at the result. The first line brain RT failed to improve the long-term survival in EGFR TKIs with asymptomatic brain mets. You need, please see this. Ultimately, what does the patient want? Patient doesn't want radiation oncology. Patient doesn't want medical oncology. Patient wants survival. Did it change? No, it didn't. Again, a meta-analysis of the data which was presented, 4 studies, major studies. Again, there was no data which was increased, which would say that OS or IPFS was better. Nothing changed actually over there. So what did we learn today, Dr. Indu Bansal? We learned that even with first and second generation TKIs, there was no need to treat asymptomatic patients with brain RT. Now let's move on to the next generation TKIs, you know, the young Turks of Indian cricket, which are basically going to break the blood-brain barrier. Look at the disease control rate in Dr. Indu Bansal, 93% with osimertinib, not 2%, 3%, 93% whole brain control rate. Look at, and you said what, retrospective data? Flora and Aura are prospective randomized phase 3 trial designs. Please look at the CNS disease control rate. And we are not talking about only one particular lesion. Dr. Shyam Agarwal is smiling already. 90%, 95% disease control rate. Where what you're talking about retrospective disease prospective data. Now I will tell you. Patients who had no treated metastasis, patients who had treated CNS metastasis. 15.4 months with and 19.1 months without. You spoke about 8 to 9 months, 10 months. This is osimertinib, your favorite drug, Dr. Indu Bansal, not mine right now. So this is what, you know, I mean, osimertinib is actually going ahead right now over there. And just thought when you thought it was all getting over, you spoke only about EGFR, you know, EGFR is only 70-80%. Now let's talk about alectinib. Look at this, patients who had received either if you get brain RT or no brain RT, you had an HR of 0.44 or 0.34. That basically means that even if you don't give RT, that drug is going to work very, very well. Very, very important. Does SRS prevent the development of new brain mets? No, it doesn't. Look at this. Only 4%. Look at this. Alectinib, 12 months CIR, controlled intracranial. Only 4.6% of patients will have disease progression in the brain if you give alectinib. Dr. Indu Bansal, that is 96%. SRS, I don't want to go to that again. Alectinib is not the only one. Look at the intracranial response rate of ceritinib, alectinib, brigatinib, ensartinib, lorlatinib over here. And this is what Dr. Indu Bansal actually feels right now, you know, the tsunami of all the TKIs that is actually coming over here. So what will you debate tonight? I knew you will come with this article, you know. Dr. Indu Bansal said recent article. Now, ladies and gentlemen, for medical oncologists, 2017 is not recent article. 2017 is old article. It was pre-2017 series. Osimertinib, alectinib not included. Retrospective data. 76% of patients did not have an extracranial disease. They did not account for the quality of life data. You never know whether they took oligometastatic patients or not. So this data was biased. What do the Indian consensus guidelines say? Let's talk about India. We spoke about SAARC. They basically say in patients with druggable oncogene driver mutations, TKI may control the disease better. Do not use whole brain RT. Do not use whole brain RT over here. So whole brain RT for NSCLC, I don't think is going over there. I'm just going to start. This is a conversation that, you know, Dr. Indu and a patient actually has. So Dr. Indu Bansal tells the patient, you know, you have been diagnosed with stage 4 lung cancer, which is spread to your lungs, bone, liver, and brain. Patient says, oh, doc, that's bad. Do I have a chance? Indu says, yes, you know, but fortunately, you have an oncogene-addicted lung cancer. This means you can be given an oral pill. But the patient says, yes, doc, I'll get an oral pill. And Dr. Indu says, you know, I will first give RT to the brain. It's a new, latest, savvy technique. Patient says, okay, doc, I'll do that. But then, will it I also require RT to the lungs, liver, bone, etc.? Dr. Indu says, no. For that, your tablet will take care. The patient says, doc, but doesn't that drug cause the blood-brain barrier? He says, yes. The doctor says, but the patient says, but I do not have any symptoms in the brain, no headache, no vomiting, no giddiness. Dr. Indu says, no. The technique is very good, savvy, latest, no side effect. Then he says, you know, even if the drug I take, does that mean that the new lesions will not appear in the brain? He says, no. For that, your new oral medication will have. But then the patient says, okay, doc, I'll take RT, but tell me, is there an OS advantage? Indu says, no, I don't think there is any advantage of that. For that, go to Dr. Ullas Batra, he will take care of that. So the patient says, doctor, according to you, the drug acts in the brain the same way it acts in the entire body, has no increased side effect. There is no evidence that increases overall survival. Should I not start with the oral medication and reserve RT for the later? And that is exactly what the patient will go and tell, that Dr. Indu Bansal should actually go and tell that this is the right choice actually for you. And that is what exactly I am going to say. And to conclude, third generation TKIs have got increased intracranial disease response rate. There is no toxicity. WBRT should be avoided. There is no robust data of SRS in addition to third generation TKI. Always remember the first law of the medicine. That is, first do no harm. Treat the patient. Do not treat the report with this. And this is for you, doctor. This is for my esteemed opponent. And it's a Trump wine from me to you. It is made for SAARC grapes. And any relation to the debate is absolutely not warranted over there. With this, thank you. And I'll go back to the moderator for this, who is already smiling. Dr. Sham, over to you.
Okay, so do we give Indu a chance or I go ahead? Indu, you have one minute.
So I just want to say, my dear worthy friend, I think you took everything wrong because you were thinking only about medical oncology and nothing else. And very smartly, he played the game that when it was, when we were talking about overall survival, about radiation, then he was talking about overall survival. But when we were talking about alectinib, loratinib, or any other drug, then he was showing disease control rate, progression-free survival. And I never said that there is penetration of 2%. So you were not listening at all to my talk, Dr. Ullas. I showed there is a response rate of 60 to 70%. So and 2%, I said only 2% drugs cross blood-brain barrier. So please at least listen to what the opponent is saying.
Right. So I am not going to take any sides. I am on the side of the patient. So I'm neither on the side of radiation, neither on the side nor on the side of medical oncology. So I've already put this as a medical oncology dilemma because most of these patients are coming to medical oncologists and the ball actually is in the court of the medical oncologist whether he or she should be referring the patient with brain metastasis, asymptomatic, to the radiation oncologist or not. So, right, Ullas, you agree with this?
I always agree with you, sir.
Right. So let's have the next slide.
I have to live also, no?
So the issue is now, I mean, I think we understand that radiation has ruled the roost over the years for brain metastasis. And the issue in the mind of medical oncologists and treating physicians is, can we avoid radiation? So these are a few issues which I have, put down here. Number of METs, size of METs, 3 centimeter or less. Whole brain RT is to be avoided at all costs because these patients are going to live for long periods of time. SRF is safe and preferred. We all know. I think Ullas also agrees with that. We have drugs which cross the blood-brain barrier, but the problem is that the effect of the targeted drug is not assured because Ullas agrees 70% response rates, which means 30% patients are not going to respond. And the problem with the TKIs is that the effect of these drugs are not long-lasting. It's only going to be for a 10 months, 12 months period of time, although ALK and ROS are doing better than the EGFR. But the tendency in medical oncologists is to avoid whole brain radiation or SRS for asymptomatic cases, as Ullas made the point. So now let us come to a few case scenarios. Next slide, please. So I think this is a statement which I have to make here before I go to the case scenarios. There is no head-to-head prospective comparative trial between targeted drug alone versus SRS and targeted drug. So I think that is going to sort out the problem, which we don't have. What Indu showed and what Dr. Ilash showed, they were all retrospective studies, not showing any OS, etc., etc. So such trials with osimertinib are going on. So in the absence of such data, I think we just have to live with the data which we have and still perhaps discuss with the patient. So let's go to the scenario. Next. So if you have a patient, which is not uncommon, three lesions, 1 to 2 centimeter each, asymptomatic, targeted therapy is available which crosses the blood-brain barrier. So do you do SRS or not? So that is the crux of the matter here. So, because the response rates, as I said, are approaching 70%, and the medical oncology feels that the patient is asymptomatic, let us not give the radiation. Size of the tumor is less than 2 centimeter. So that is where the problem is. So what do you do with such a patient? Do I send this patient for SRS, which is going to be a 3-day or 4-day affair, costing around 1.5 to 2 lakhs? Or do I start with my osimertinib and do a close surveillance? So that is the issue here at this point in time. And I think there is no clear answer. It all depends how you put it across to the patient. How do you explain to the patient whether he can afford the 3rd generation TKI or whether he cannot afford the 3rd generation TKI? I think close surveillance is an option because there is no added advantage of radiation in the overall survival. But yes, you have to be careful. A patient can deteriorate, as Dr. Indu showed. Patient can have convulsion. Patient can have progression of disease in 30% of the cases. So I think it is not an open or shut game at this point in time. So my take would be to discuss the role of SRS, explain close surveillance versus SRS, and let the patient take a call. Next, please. Next scenario. So when the number of lesions are, less than 10, asymptomatic, again, the drug is available. So I think this is again a similar kind of a scenario, but there I think the medical oncologist is tilted towards offering radiation if the number of lesions are more here. So if they are like more than 3 or 4 or 5, then I think, but I believe, I think there are a lot of medical oncologists, asymptomatic patient, again, close surveillance could be an option. So I think we don't have a clear answer here. The last slide is on the number of lesions, if they are more than 10. So there, the issue is SRS is usually not possible if you have 10 or more lesions and if the total volume of the disease is more than 15 ml. So I think there again, you would like to go for either whole brain radiation with hippocampal, sparing, as Dr. Indu showed. But I think these still remain gray areas in the absence of head-to-head prospective trials. So I think that's my last slide. Next slide, please. So I think we need to study the following: comparison of a targeted drug alone versus targeted therapy plus SRS in patients with asymptomatic METs. I think we are getting good response rates, and these response rates are not lasting. So therefore, SRS cannot be ruled out outrightly for patients who have asymptomatic brain mets. Well, that will be my take, perhaps a balanced view here.
So I want to make just one point here, just one point. I am what I showed was that I would say that I would like to incorporate SRS only in few situations. Number one, if the patient is L858R mutation positive, if the lesion is cystic, if the lesion is in such a location which if progresses can lead to harm to the patient. Number four, as I said, that if it's in, say, in the frontal area putamen and it's a rapidly enlarging.
Right, Indu, I think there is no data like this to my mind. So I think we are even willing to refer all cases of 3 metastases to you after discussing with the patient for SRS, because it is a safe technique. It doesn't give you any major side effects. So we are in full agreement with you, but I think we need to document that. So last, you want to comment? The last comment from you.
Yeah, sir. I do want to see that the thing here is it is asymptomatic. So my take on this is you treat with osimertinib, keep or alectinib. You have a CR rate of 38% that you get with alectinib. You have a disease control rate of 90% that you get with them. And when the lesion progresses, definitely SBRT. No doubt about that. What I'm saying is start with TKIs, keep a close follow-up. Patient is asymptomatic. Why do you want to give SBRT upfront and treat a report and not a patient? So, I mean, to answer your question, Dr. Indu, the subset analysis data is all retrospective. L858R, DEL19, there is no prospective data which I said. Maybe the only data for osimertinib is in L858R, it doesn't act that well, but that's not sure. I mean, that's again a retrospective subset-based analysis, which we are not sure. And definitely in brain mets, there is no difference about that at all. So I don't think you only on the basis of
SRS.
Right, Indu, last comment. I think this is an debate. Yeah, Indu.
Yes, so the purpose of I'm saying that TKIs are going to remain the main treatment, but the purpose of introducing SRS is so that you can continue using the same drug and reserve your subsequent lines of therapy for later use to increase the progression-free survival, intracranial control rate, and you can use it as a reserve.
We agree with that, but we don't want to start with SBRT.
Close this. I think the issue is close surveillance on a blood-brain barrier crossing TKI versus immediate SRS. So I think that is the issue which cannot be resolved unless you have a head-to-head prospective trial. I think we close it here and thank both the debaters for an excellent presentation and an excellent debate. So thank you both.
I have a disclaimer actually. Yeah. Dr. Indu, I mean, my slides actually were 3 days old. The slides which I had sent to them at some other PPT opened actually. So the new slides are very interesting. I'll use it in some other debate.
Okay, so I think Purvish can use your new slides in a subsequent debate, So thank you very much. Thanks organizers and all the people who are listening from Bangladesh and from Nepal and other countries. I think it was a wonderful debate on the subject. Thank you very much.
Thank you so much.
Thank you so much, sir. Thank you to both the debaters for a lively debate. We'll move on to the next session. This is the academic session 5. It's on GI. Our moderator is Dr. Vamshi Krishna, medical oncologist from Hyderabad. His panelists are Dr. Anand Ramaswamy, medical oncologist from Mumbai, Dr. Shailesh Bondade, medical oncologist from Nasik, Dr. Adwaita Gore, medical oncologist from Mumbai, and Dr. Snita Sinukumar, surgical oncologist from Pune. Over to you, sir.
Good evening, everyone. Am I audible? And I hope my slides are visible, Kashish?
Yes, sir. You're audible and the slides are visible.
So, good evening, everyone. And we just had a very entertaining debate with fireworks. I don't know if I'm happy or not that I don't have a radiation oncologist in my panel, because I would have expected similar fireworks considering the topics that I have put. We have a very good panel here. We have one of the oncologists working in the premier teaching institute of India. We have an oncologist working in a premier corporate hospital. We have a surgical oncologist, and we have a medical oncologist very experienced working in what we can call a tier 2 city. So I think we'll get a whole spectrum of reactions and whole spectrum of options of treatment. And as always, we would love to have a focused discussion and not really digress too much. So let's start off with the gastric cancer. Now, this is just a random case of 55-year-old lady, no comorbidities, only dyspepsia, endoscopy showing an ulcerated growth in the antrum, PET scan showing a growth in stomach, antrum with few perigastric nodes. Now, this is something we commonly get. So, starting with Dr. Snita, what is your practice routinely nowadays, ma'am, for surgery or NACT? For stomach cancers, we are talking of gastric here.
Yeah, so this is a distal gastric cancer. If the patient is not obstructed The approach would be, depending upon whether it is locally advanced or not, the approach would be surgery first in an obstructed patient, of course. And if the patient is not obstructed and it is not locally advanced, again surgery. In the presence of significant perigastric lymph nodes, I would first consider neoadjuvant chemotherapy and then surgery.
Dr. Smita, this is the report we normally get. The report says few perigastric.
This patient, I would consider surgery first.
All right. So the question I want to ask is, we have often seen these reports as medical oncologists where they write few, and then we see the report 8 out of 20 lymph nodes positive. And, you know, we are kind of stuck in that situation because we're having 8 nodes positive. So what would you think? There are a lot of data which says that nodal staging is not as easy as it seems to look. So what would your thoughts be on that?
I would assess in terms of operability. If the patient is operable upfront, I'm going to operate the patient.
And that operability depends on the PET scan, if I understand you correctly.
Yeah, PET scan, CT scan, anything that does not suggest it is T3, N1 and above.
Any node positive becomes an N1.
Yeah, but then if a few perigastric lymph nodes, it's quite a vague report. But with a report like this and an ulcerated growth, I really don't know what the T status is. I really have not seen the scans. With a report like this, I assume that it is operable early stage cancer. I would go ahead with surgery.
All right. That's fine.
Probably more information. Yeah.
Absolutely. Dr. Advait, what is your take on this? For Dutch patients, would you still prefer any neoadjuvant treatment, or would you prefer for surgery?
Vamshi, what you put up is a very common thing that we see in practice. And especially in such situations, the lymph node status is the actual deciding factor that the surgeon and the medical oncologist actually sit together over coffee and decide what is to be done. Now, the situation here is that it entirely depends on how comfortable the surgeon is getting an adequate nodal clearance. We know very well that, yes, giving neoadjuvant chemotherapy with FLOT 4 cycles has shown that the complete resection rates are better. But as I said, it's a multidisciplinary team approach that we follow here. And with just few perigastric nodes, which are centimeter, sub-centimeter in size, I would tend to go towards surgery, especially we don't know the T stage of this patient.
Perfect.
Absolutely.
Dr. Shailesh, if I could just bring you in a possibly a center. I mean, I know your center is something you have worked on for so many years, so I'm sure it's more established there. But in general, in a more tier 2 city where you don't have a institutional approach, what would the general approach be? How comfortable are surgeons not operating and giving NACT?
So in this particular case, I presume that we are dealing with an adenocarcinoma. Okay, I don't have an histopath here, but let's take that as an adenocarcinoma. Okay, so in this situation, the first thing I would like to do is go for an NACT upfront than a surgery. And before I plan an NACT, I would do a diagnostic laparoscopy just to rule out peritoneal disease, because sometimes we have burnt our fingers that there are peritoneal lesions and we think of giving an NACT when it is absolutely a palliative treatment. So NACT first, obviously a diagnostic laparoscopy followed by NACT and then surgery. And NACT, obviously we are using FLOT as of now.
Okay. So Dr. Anand, if I can bring you in at this point, you're obviously working in institute and definitely a much more organized multidisciplinary approach works there. You would probably get a review of the radiology done to know the number of nodes. So if I can just ask you, what's your take on where are the cases you would operate first, where you would definitely not operate first?
So we follow the older criteria that unless there's a perf, obstruction or hemorrhage, we would give neoadjuvant. The only other indication is an early gastric cancer, which we normally don't do an EUS, but we would do an EUS, prove that it is T2 or so, and then yes, surgery upfront, or else we would give neoadjuvant and then operate. I agree that both approaches are valid. The only thing is that once you go in with a potentially node positive disease, you could probably find more disease than less disease. So, a neoadjuvant intent probably would be better, but it cuts both ways.
Fair enough. So I think there is a lot of emerging data on NACT, especially when you're suspecting node positive disease, especially when you are also looking at a situation like Dr. Shailesh said about peritoneal disease. So this question has been pretty much answered. So my question now is, if you do give NACT and after that we opt for D2 surgery. So Dr. Snita, what would you say? How common is D2 surgery in India now? Or I'm just asking India because that's what we are mostly used to. The D2 dissection.
I think we are pretty much resecting the stations as per the local regional disease. I think we're pretty much following the guidelines for D2. Yes, adequate lymph node dissection.
Dr. Rajeev, what has been your experience? Patients coming to you, all are coming with D2?
Dr. Vamsi, this is with regards to, I don't know about the other, but most surgical oncologists trained.
Fair enough. I just wanted to,
so
this is a SAARC meeting, so we should have an idea what is the general practice in our community. I'm not going to ask Anand because at TMH, obviously they'll be doing a D2. I don't need to ask him that. So I'm just asking community, what is our general experience? Dr. Advait?
Yeah, Vamsi, in actual community, when we get to see patients, I would look at about 60% patients undergoing a D2 clearance and still about 40% patients who undergo a basic D1 level clearance. And that is where the major change needs to happen. It primarily is because not all patients get operated at specialty centers where these kind of surgeries can be done. And that is what we see in clinical practice outside of an institute.
Absolutely. But I have to say that at least in my practice, the amount of D2 that was there, say 7-8 years back compared to today
it has better. It is much better.
That is
one much better, Vamsi. When we were in training about 10 years back, we used to hardly see about 15 to 20% patients undergoing a D2 clearance, but now it is much better.
Absolutely agreed with you. Dr. Sailesh, we don't have a radiation oncologist, so just coming to you. Supposing post NACT, you still have disease left. You don't have a CR. That's not very common. You have, say, 3 lymph nodes positive, T2 disease. What would be your indications for radiotherapy in this post NACT setting and a D2 dissection?
So post NACT D2 dissection, and I presume it is an R0 resection.
R0.
And I presume that the margins are negative.
Yes, R0 negative.
Okay, so with this situation, I would only go for chemotherapy again and non-radiotherapy, provided it's a D2 surgery.
Yeah.
Anything different from what you're doing in PMH now? Role of RT post NACT?
We are not giving RT at all, and there is good enough data for that as well if there is a good D2 done.
Perfect.
Anybody thinking of a diffuse type of pattern and females having this? I mean, there is some subset analysis of some study which shows a diffuse pattern of involvement of stomach, and in females that maybe an RT might have a role.
I think the only 2 robust criteria is heavy nodal burden and a positive margin and an incomplete nodal dissection. Yes, absolutely. I mean, anything other than that is not a soft indication.
So let me come to other situation where we do see an upfront surgery being done, and then we find, like I said, some nodes are present. You know, it could be 8 nodes, it could be 20 nodes. So how do we sequence? And Anant, you can take this. What is your criteria in post-operated cases? Role of adjuvant or role of CTRT?
So,
just the final conclusion.
Yeah, we stick to the earlier criteria. Unless there's a margin positivity, we do not give adjuvant CTRT, we give adjuvant chemo. Margin positivity, yes, we use a sandwich protocol, which is common. The heavy nodal burden is actually a question that has been answered now. Artist who has come out with freedom data which says that there was no benefit for RT, even though that was not the primary endpoint, but largely that's out as well. So we just give adjuvant chemo.
So now let me just come to GE junction adenocarcinomas. Here, where is the role of CTRT in a neoadjuvant setting? Is there any data for that, Dr.
Definitely.
Yeah, obviously. Cross trial has really cemented the position.
The cross versus the flot. What's your general practice?
So as I said, it's a distinction which one has to make based on whether it's Sievert's type 1, type 2, or type 3. If it's a Sievert's 3, then it goes straight away as a flot. If it's Sievert 1 or 2, then you would treat it like a cross.
What about an operated case? Again, this happens. Operated case coming with, say, T3 and 1. Any role for RT, or would you just give adjuvant chemo at this stage?
Difficult choice, but probably I would.
The FLOT study had a fair number, I think 40 to 50% of proximal cancers.
Correct.
And they, and even the Southeast Asian studies from Japan had a fair number of proximal cancers. And you would go with chemo there as well.
So in any case, my question again, when this C-word 1, 2, 3 is more of practice, is there any hard evidence to say that, in 1 you have to go with cross and 3 you go with, and I really don't know the data, but I agree that a lot of us do practice in a similar way. So again, just to come to what I was thinking, what is the indication of RT today in a gastric cancer? Other than a positive margin, do we have any strong indications? I can get away by making such statements. I don't have a radiation oncologist in my panel today. I'm sure everywhere else the radiation oncologists are ready to tear out. But seriously speaking, Anant, in TMH, for example, G junction and stomach. Other than a CTRT for G junction and a positive margin, where are the indications for RT today?
I can't think of any other indication which has been studied. A lot of our cancers come with bleeding, so we give them hemostatic RT is a different story. But I can't think of any other studied indication.
Dr. Shailesh, what's your take on this? Because again, like I said, you are working in a center where probably so much multidiscipline may not happen, or in other secondary centers. Again, like I said, I know your center is different.
I think I agree with Anant that other than this, I don't think any other indications for RT.
Dr. Snita?
Agree with the other panelists.
So it's a beautiful friendship between the medical oncologists and the surgeons here. So the radiation oncologists are not there to tell us. But at least these are my summary, and this is again my own, what my conclusions are, that a neoadjuvant therapy has become a standard of care in gastric cancer, except early gastric cancers. I am not very convinced that we can ignore any notes seen on a PET scan. We should go for NACT in such cases. In gastric adenocarcinoma, NACT is with FLOT, it's by and large become standard. Role of RT has diminished across most of the gastric cancers. In adjuvant setting especially also, there is hardly any role. Only confirmed benefit is probably in patients with a positive margin. G junction tumors, yes.
Sorry, I cut you in between.
Okay.
Regarding the role for the post-operative radiation in this situation, there are certain situations, like, see, most of us are still very, very academically oriented, but some of us are not in a multidisciplinary team institutions. So for the benefit of those, if we need to consider adjuvant radiation, there are a few things which I would like to bring out, which I would want the other panelists also to give their comments on. As I said, there are about 40% patients who don't undergo a D2 level clearance. Correct. You would have patients who have less than 15 lymph nodes on the histopath specimen, and you don't know whether the nodal clearance has been adequate. You have younger patients. We get patients who are as young as about in their mid 30s or even younger than that in their late 20s who present with this. And those patients who have a disease which is greater than T1N1 disease, probably one would look at, if they have not received neoadjuvant chemotherapy and they have undergone upfront surgery, probably these are the candidates that one should look at, where there may be a potential role for radiation in post.
I'll just let Anant have the last answer on this, and then we move on to the next topic. We are already 12 minutes. Anant?
Yeah.
Your comment on this.
I'll take Dr. Advait's point on D1.
Exactly.
That is fair. Yeah. That is a important point that we missed. D1, yes, you would maybe consider RT. Okay. But D1 and margin, yeah, the rest maybe not.
Very good. So again, knowing when it has been D1 versus the D2 is sometimes not as easy. Most, let me say, general surgeons do not really tell you what nodal dissection is done. We have to read between the lines. But these are two areas where we would agree with that. So coming to now to metastatic colon cancers, and let me just start with Dr. Advait. Is this debate over, right-left debate over, or is there still something to discuss on this?
I think it's been overcooked. And for the last 3 years, it's been discussed so many times, and I think at least in terms of the first-line treatment options, it's done.
Very good. So, Dr. Shailesh, for left-sided, right-sided metastatic CRC, what will you do as the molecular tests?
So, as of now, we are doing ALRAS, BRAF, and MSI.
For all, both left and right, or only for the left-sided?
We are doing for all metastatic colorectals.
Fair enough.
I add HER2 also, Vamshi, to this.
Yeah,
HER2 okay, by PCR or FISH or IHC? It's a complication for me because I do it usually by IHC. I know that
it's a complication. It's a complication for us also. Now in-house we have a FISH and IHC, but if you need to send it to PCR, it has to be to a referral lab. So that's generally what we do. That first we get it in-house and then we see.
Dr. Anand, TMH policy now, send for PCR
So we do a RAS, RAF, and MMR, MSI or MMR. We are not doing a HER2 right now. Because we have a mix of affordable, non-affordable patients, it's a stream. We do it in patients who have received anti-EGFR directed therapy on progression, because then the pickup rates for HER2 become much more.
Okay, but if you clean it up upfront, you would not give them the EGFR in the first line.
So one, we don't have deruxtecan in this one. Two, trastuzumab has negative data. So then maybe not.
Taking doesn't make much sense. I agree.
Anant, how often are you doing BRAF or only for right-sided tumors?
We are doing RAS and RAF for all.
Okay.
For all.
I think that's by and large our practice, even though we know that it may not really change your first line as
yes, I was
end up doing it. Just because in second line you can use that same data. I think that's what we have been discussing for last 3 years, and I think we are good with
5 years now. Yeah.
5 years now.
Yeah.
Is IO a viable option for us in India, considering its cost, considering that it's less than 5% of MSI? I mean, MSI high, I have not found in the last, 1 year since I've been looking, but I don't know how common it is. Anant, your call on this?
So we are doing the MSI. Obviously, I've offered it to, in the last 1 year, 5 patients.
Okay.
And it's very nice. I mean, for sure it works. I've not seen anyone who has that hyperprogression, which is seen in the data.
Okay.
It works, but very few numbers.
Very interesting, because for us, the bane of hyperprogression is more for the head and neck, where you really see hyperprogressions.
Yeah.
Hyperprogressions other places. Dr. Shailesh, sir, your experience, how much common is this MSI? Are you doing it routinely?
Not for everybody, but for very, very few. Not found anybody with positive results, and obviously not used an IO for any of the patients.
I think the take home for the audience is, yes, MSI looks nice. You'll go to any data or any American or any European thing, they keep talking of MSI. In India, well, it's good to do if you can afford and if your patient is affordable. If you don't do it, I don't think you should really beat yourself over the head. RAS-RAF at this point, probably you should do it for all, at least offer it for all. MSI, well, if you can do it, it's good. Because bottom line, Dr. Shailesh, how many of your patients take any targeted therapies in the first line?
10 to 15%.
10 to 15.
Not very high.
About 30-35%.
30-35. That's very good. I think in my practice, it's around same 15% what Dr. Shailesh was saying. Anant, in TMH?
So we've actually sent this for publication. It's exactly 15%.
15%. So I think end of the day, we have to also, we should not get lost in this era of all these things. Academically, it's nice to discuss. Remember, 85% of patients are not going to get any targeted therapies. Around 80%.
Vamshi, and most of our patients are actually on bevacizumab, which is the generic one, which is actually cheaper than the others. So
absolutely.
That's how the number is 30%.
So again, I think for 5 years, we have been talking a lot about all these things, but yes, at the end of the day, 80% we don't do any of it. But still, it's a good to know all this. Okay. Coming to HCC. Now, I just had a small case for HCC. We have some 10 minutes left, so we'll just go a bit quickly. 48-year-old gentleman from Africa, found to have a liver lesion, PS2, no encephalopathy. He is basically CPS B7, AFP very high, HBS DNA positive. Look at this lesion, a huge lesion of around 12 centimeter with few satellite lesion, not really symptomatic for this lesion per se. No, not having pain, no bleeding, no such symptoms. So in such a scenario, let Dr. Snita, what's your take on such patients when they come? Would you send them for a taste tear or some local therapies, or would you straight away start on system?
So there is portal vein thrombosis.
Correct.
In the presence of portal vein thrombosis, I will not be very keen on considering TACE for this patient.
TACE is
tear, yeah. So tear might have a role, tear along with sorafenib, probably, yeah.
Okay, so Anant, tear with sorafenib, is there any data of a local therapy with sorafenib working?
Yeah, so except for the Japanese study on tactics, which I love quoting, there is, there are 4 negative studies for TACE plus sorafenib. TARE plus sorafenib also, there is some negative data. If we agree that the gastrohepatic and peripancreatic lymph nodes are actually significant, then maybe not even TARE and only systemic treatment.
Very good. What about multicentric? Because this is a multicentric disease, not just this case. My whole reason for asking is it seems to be a reflex among most oncologists to first try a local therapy when you see a big lesion sitting there, despite having other lesions in the other lobes or else, like you said, nodal disease. So any evidence to say that this is better than is it just giving systemic therapy better than doing all this? Dr. Shailesh, your take on this.
For me, this patient is actually for a systemic therapy right away.
Right. Okay.
No local therapy.
Your take on local therapies, just because you have a big lesion which can be given TACE, patient already has disease elsewhere, would you still go ahead with TACE, or would you give it only if symptomatic?
I think, Amshi, we follow the BCLC staging criteria to decide whether the patient has to go for local therapy or a patient is suitable for systemic treatment. And you rightly put up in the slide that if the patient is either very early stage, which is the BCLC 0 or BCLC A, then these patients can be looked at localized treatments. And patients who are intermediate stage B, then they are somewhere in the borderline where some may go for the TACE TARE, some may go for systemic therapy based on naturally how the symptoms are. At the same time, we also know that these localized treatment don't really bring about a very rapid symptomatic relief in patients as faster as the systemic therapies like the VEGF oral TKIs do. As Anant was mentioning that, yes, there are a lot of data which have mainly negative for looking at maintenance oral TKIs following a localized treatment. There is newer data coming out on nivolumab, which is post-TACE and TARE, which is showing exciting results. So we probably would get some newer drugs for this, but as I said, most of the patients in such situations that you showed the scan slide back, I would look at systemic treatment for this patient.
So again, the point I really want to highlight is this, PS1 and 2, forget PS3, 4. PS1 and 2, according to BCLC, should go for systemic therapy.
Systemic treatment.
PS0 is the only place where you should actually use chemoembolization. Now, I think that's a little bit aggressive. We probably PS1 we end up sending to this, but any extrahepatic spread, there's really no point in doing local therapy unless you're looking for local symptomatic control. I think that's an important take home, because it seems to be a reflex that patient is immediately sent off for any local therapies. A larger lesion really will not help much. So again,
also,
I think
child book scoring is also important if you're planning a system.
Yes. Any
child book is a part of BCLC. Which, you can't do BCLC without child book.
Right.
Yeah. So Anand, in TMH now, what's the status? You have a meeting for all cases which come in and then only go for TACE, or what's
so assuming this patient did not have nodes, right, just for discussion's sake, and they were affordable, you may have considered for TARE. Definitely not TACE.
Any data for overall survival advantage in TARE anywhere?
The problem is TARE has not really been studied appropriately. So you don't have that kind of great data. So if someone says, no, I want to give only systemic therapy, they are bang on. It's just that the data for TARE is not great in terms of prospective studies.
It seems to be something that has a lot of enthusiasm, but somehow less of evidence that seems to be there that TARE really works. And of course, the SBRT coming in a big way and hypofractionated RT kind of replacing TACE. Again, yes, I can see that you are not a big fan, but it's what it is. In practice, especially, we do see.
I like this option of yours, TARE for the large lesion, RFA for the small lesion, giving a systemic therapy.
There is in fact, Vanshi, there is in fact data coming out to give SBRT for the portal vein thrombus also.
That is the difference.
I don't know.
So that is exactly what I have written in the last. It's a bridging therapy. You can use it as a bridging therapy.
Bridging therapy. Yeah.
When you want to go for a transplant, there it is good. You give local SBRT, then you can make it bland and later go for a transplant or resection. There is good data on that. I absolutely agree with you. Right.
So 4 minutes left, sir.
Yeah. Last part, pancreatic cancer. So most important part, Dr. Snita, how do you define this borderline operable cancer pancreas? Not locally advanced, I'm talking about borderline operable.
Yeah, you have it on the slide.
Yes. No, the reason I'm asking is, again, this seems to be very, I have patients referred to us for NACT where I really didn't know why it was referred. Is it borderline or is it LAPC? So I want to know in practice, how well do surgeons define this? Do you define it as a borderline? Yes.
So I'll tell you a very practical approach. Let's forget about the definition. I read the scan and I understand that there is a very high possibility for me to get a positive margin when I'm going in at surgery. I will send it for NACT, NACT-RT. Very, very simple. So it's a lot. You have objective definitions to guide you. That is true. But like you said, that there is always this, like, the medical oncologist doesn't understand probably, or it is not in concordance with the surgeon's
I really
decision.
don't know how to understand why we have given a
just a comment. There was some surgeon talking at TMH. He said, if we can draw a circle around the tumor, it is operable.
Yeah. So at the end of the day, it is quite a very objective as well as a subjective. You want negative margin. The whole purpose of all this neoadjuvant chemotherapy radiation is that you don't want to get a positive margin at the SMA. The minute you realize that on imaging scan, and that this you'll probably leave behind disease, I think it's safer to consider this patient for a neoadjuvant chemotherapy, radiotherapy.
Again, if I understand, it's still for me, it's still subjective, because I can understand.
Absolutely. Yes, it is.
It has gone into a vessel. You cannot do anything about it. It's absolutely. Absolutely fine. This borderline resectable is something where I struggle to get my head up. Doctor, if patient comes to you NACT versus NACTRT versus the latest thing, that is SBRT, what's your take on it?
So the data is there for both. Yeah. When we actually sit and evaluate the patient characters, age, comorbidities, the performance status, everything is put into perspective along with the organ function, and then that decision is taken. My preference would be to go in for NACT rather than CTRT, because many of our patients are not suitable enough to go for the combined modality treatment. That is what on a practical level that I follow.
Anant, a lot of trials, you're having trial on neoadjuvant SBRT followed by surgery. You have, I think, a trial on NACT as well, isn't it?
So I'm a big fan of SBRT in pancreas.
Okay.
So I push everyone for that. And
or locally advanced?
No, I'm talking of only BRPC.
Okay.
And so what we do is based on fitness, as Dr. Advait said, either Gemnap-Paclitaxel or FOLFIRINOX, and put in SBRT somewhere, because I truly believe that it helps in sterilization of margins.
So basically, you're talking about TNT kind of protocol. You're talking about total neoadjuvant.
Some neoadjuvant. I don't know whether it's total or not.
In both radiation and chemotherapy.
Yeah. Unfortunately, just a week back, there's data from Alliance which says that SBRT doesn't help.
Oh, that's interesting.
So, yeah. So it's a iffy data, early data, only the abstract is there. Right. So they said it does not help. So a little bit of a, but NACT for sure, and try and give SBRT is what I try. Yeah.
Okay. Very good. So I think in practice, in pancreas also, we are kind of shifting to a neoadjuvant approach. Seems to be following other places. SBRT versus a hypofractionation. Again, we don't have a radiation oncologist here, but we do talk of SBRT in 2 fractions. Then my radiation oncologist will see it and say, no, I'll give it in 6 fractions or 5 or 10. So essentially some radiation, maybe not a CTRT, which like Advait was saying is not that easy to take home. So for me, the take home message on the pancreas section is just that some neoadjuvant should be used. And again, assessment is very important. Documentation is even more important, at least as far as I'm concerned. So with that, I would like to conclude. I thank all my panelists for a great discussion, and over to the organizers.
Thank you.
Thank you.
Thank you so much, sir. Thank you to all the panelists. We'll now move on to the rapid fire session. The topic is the most important single publication from your country. And representing India, we have Dr. Amit Joshi, medical oncologist from Mumbai. Over to you, sir.
Yes, sir. So I think the most important publication in the last 1 year, I think, is the low-cost oral metronomic versus intravenous chemotherapy in recurrent, inoperable, and metastatic head and neck cancer. It was a phase 3 randomized study of cisplatin versus the oral metronomic chemotherapy of combination of methotrexate plus celecoxib. Next slide. So we all know that the options are very limited, and we need and whatever the available options are very, very costly, and hardly 1 to 2% patient can able to receive these the options. Next slide. So we have previously done a phase 2 trial which has shown that the OMCT is effective, and it can be a substitute for a cisplatin. So next slide, please. So we hypothesized this study of head and neck cancer palliative patient. They were randomized into 2 arms. One arm received the standard single agent cisplatin, 75 mg per meter square 3 weekly for 6 cycles, and the other arm received the our standard of ONCT, that is methotrexate 15 mg per meter square and celecoxib 200 mg BD. Methotrexate was it was a weekly dose, and the primary endpoint was OS. Next slide. And this was since all factors were well balanced in this point, the majority, as expected, majority of the patients were from the oral cavity, and majority of them received some sort of previous cisplatin based therapy more than 6 months back. Next cycle. So this study, coming to the results of this study, this has shown a clear-cut benefit in terms of the PFS. The PFS was in the chemotherapy arm was around cisplatin arm was around 2 months, whereas it was around 4 months in the ONCT arm. Next. And study met its primary endpoint. The overall survival was in the cisplatin arm was around 6 months compared to the ONCT, which was around 7.1, and the p-value for this was 0.02. So this ONCT was superior to the single agent cisplatin in palliative setting. Next slide, please. Next slide. So I think coming to the safety profile, as expected, the ONCT was definitely more safer than the cisplatin in this scenario. Next slide. Coming to the quality of life, in this quality of life data also says that ONCT not only it improves the survival with less toxicity, but definitely has a better QL compared to the cisplatin. Next slide. Thank you. So I think with this trial, the role of ONCT, at least in recurrent metastatic, is very clearly established.
Thank you so much, sir. Now we have our second presenter representing Bangladesh, Dr. Mustafa Aziz Suman, radiation oncologist. Please go ahead, sir.
So thank you. My paper, Introduction of SBRT Program in Developing Country, Challenges, International Cooperation and Experiences. It is published in November 2020 in International Journal of Radiation Oncology and Biological Physics, a very high impact journal, particularly for radiation oncologists. And here you can see the main author is Dr. AFM Kamaluddin, and I am also there as a co-author. So at first, let me inform you that why we have chosen this paper. Is because there are very few papers that is recognized by Red Journal from Bangladesh point of view, and it is also accepted as a poster in the last ASCO. Obviously, this is the success story from Bangladesh point of view, and also we want to highlight that the international collaboration definitely make things happen. So, as you know, that SBRT is a very sophisticated treatment. To start a quality SBRT program is a little bit challenging. We are talking about the year of 2014. So at the time, Bangladesh was in the era of just starting the conformal treatment. So at that time, thinking of SBRT program was a little bit challenging. So in this paper, we have tried to cover our challenges, our collaborative supports, and what we have achieved so far. So from 2014 to 2019, we have treated 46 patients with SBRT. And last 5 years, what we have done, we are really very enthusiastic to see what we have done. So we designed this study retrospectively, and we found this number of patients, and our primary objective is to see the local control as well as the overall survival. So here you can see that considering the dose, we are a little bit generous because we are at the beginning at the time. And the treatment follow, most of the patients are treated with volumetric arc therapy and daily image guidance with CVCT at the standard protocol we have followed. So considering the results, we have got a very promising results. Here you can see that the lung primary, the 2-year local control, overall survival is 86%. The metastatic result also very commanding results was obtained, as well as the liver. So in summary, we want to summarize that we have got a very commendable results. So what were the challenges at the time? Definitely, we do not have practical experiences. And at the time, proper referral from physicians was a bit challenging because the physicians were not very aware of these newer technologies. But at the same time, we got support from our regional expert colleagues, our extra-regional colleagues, and we got training from South Korea, and also the support from IE experts. At the same time, I want to mention one person, that Kartik Rajmoni, who is from India, a medical physicist. He helped us a lot, who was working in the United Hospital at the time. So in conclusion, I want to conclude with these two words, that the SBRT is encouraging in Bangladesh, and we can see that this is possible here in Bangladesh. And the most important thing I want to highlight, that the regional support really means a lot, and it can make things happen, and really it improves cancer care. That's all from my end. Thank you.
Thank you so much, sir. Without wasting any further time, I would like to hand over the mic to the SAARC Federation of Oncology Secretary. Over to you, sir.
Thank you so much, Kashish. And we come on to the presidential address. For this, I would like to invite Dr. Raghunath Rao Digmurti, sir, to co-chair the session, presidential address session. Dr. Raghunath Rao Digmurti, sir, is he there?
Good evening, ladies and gentlemen. It's my pleasure to introduce our president, Dr. K. Govind Babu, my colleague for almost 35 years now, who is the senior consultant for the St. John's Medical College Hospital and the HCG hospitals in Bengaluru. He retired as Professor and Head of Department of Medical Oncology from the Kedbai Memorial Institute of Oncology in Bengaluru. He's got a very illustrious CV, as you can see from the slide. He has several awards and honors, starting with a series of best paper awards, which is understandable since he has been an extraordinarily good presenter. It's a pleasure to actually hear him talk. And then almost about 20 more orations. So you name it, he has given an oration in that area. So people have actually found him to be very engaging, very precise, very humorous sometimes, and peppered with a lot of illustrative examples from his own life. He's got a large number of awards, as you can see, and has, to his credit, 125 peer-reviewed publications, both in national and international journals, as well as in textbooks, and a little over 160 presentations as in international and national fora. His areas of interest are targeted therapies, especially in lung cancer, and of course, clinical trials or clinical research. Beyond the academics, he's a very engaging mountaineer. He loves photography, he loves painting, but what he loves most is actually trekking. So, ladies and gentlemen, as the last part of today's program, on behalf of the organizing committee of SFO, I welcome you all to this presidential keynote address by Professor K. Govind Babu.
Thank you very much, Raghu, for that nice introduction. So I will try and see how much I can stand up to his good words. So again, SAARC, Federation of Oncology, this is the body that we have for our countries around, and this is going to be my oration for the 15th conference that we have. So greetings to you from Bangalore. This is our seat of administration here, and the rest of the country, that's India. This is for all the other people from the SAARC countries who are attending. So a few things about SAARC and why we have the SAARC Federation of Oncology. A few of these data I've borrowed actually from Dr. Baral, so I must profusely thank him. So SAARC countries comprise about 1,700 million population, and the cancer risk factors, as you can see, are very, very similar across these countries. And lung cancer is ranked first among Bangladesh, India, and Nepal. and the need for collaboration to mitigate our common problems is what actually made that SAARC Federation of Oncology to be there. And for this, I'm sure you all recognize Dr. Hai from Bangladesh, who's one of the foremost people who started this. And we are very happy that he's with us, and many people have joined him and taken this forward. So this is just to talk about the trends in cancer mortalities, comparing developed versus less developed countries. And what is projected in 2030 is that the cancer mortality will decrease by 30% in developed countries, whereas in the less developed countries, it will increase by a staggering 70%. And more than 80% of all these cancer deaths will occur in low middle income countries. And we are very familiar with why these things happen. I think the first two panel discussions actually discussed all these at length. We're talking about delay in diagnosis, lack of awareness, and the potential of value of therapy, the lack of accessibility, and abandonment of therapy. I think this is a common theme that recurs across all the countries in this region. Now we know that these 8 are very common risk factors in over 50% of deaths of these patients across these countries. And this is just to show you how much these factors influence in the high income, middle income, and low income countries, tobacco being the foremost upfront, followed by H. pylori, alcohol, hepatitis, low intake of antioxidants in terms of fruits and vegetables, human papillomavirus, physical inactivity, and thereby leading to overweight and obesity. So if you just look at the map here, the geographical world, you can see that the SAARC countries are here, but you see large continents across. But if you actually look at the human world in terms of population, you can see how huge this area is, and that can actually give you an idea of the burden of cancer problem in these areas. So let's just have some food for thought, and I will see how best we can tackle these problems. And I've tried to put it in about 4 points. The first one is tackle the complexity of cancer head-on in smarter ways, be it by basic medical research, smarter clinical trials, increased population diversity in research, and more efficient biomarker validation. And you've heard enough about the biomarker validation today. The second one is to leverage health IT department to realize unseen opportunities. I think for India, this is a great opportunities because we do have a good information technology that is there. And we need to learn from every patient, not just clinical trials, by which I mean real world data. And I will show you some of the data that we have produced in our country. Support oncologist decision making by using artificial intelligence and machine learning, and quality improvement and assessment. The third one is to expand both knowledge and means to access high quality care. This is because of the high variations we have in developed countries. Basic tools are often out of reach in developing countries, major gaps in oncologist force. So we need to look at capacity building. And I'll again give you some examples as to what SFO is trying to do on this term, and the cost, which is an issue everywhere. And the fourth point is looking at patient-reported outcomes, palliative care. Again, we have started our initiative on this, and survivorship. So what are the aspects that we can look at is, of course, this region is known for making generics, and India today is considered the pharmacy of the world. Biosimilars, metronomic chemotherapy, one of the important publications you already heard. Supportive care, drug repositioning. I will again give you some examples of that. Diagnosis, monitoring, and maybe some clinical research as well. So let me give you some examples of how we can actually look at various aspects to take care of the socioeconomic problems in this region. I'll give you some examples of what we have done in non-small cell lung cancer in our country. So this is one of the papers that we initially published, and this was looking at the pharmacoeconomic benefit of cisplatin and etoposide chemo regime in metastatic non-small cell lung cancer. So at this point of time, when we did this study, we had etoposide plus platinum, paclitaxel plus platinum, gemcitabine and platinum, and pemetrexed had just come in. And at that point of time, most of these so-called third generation chemotherapy agents were very expensive. So we thought we'll try and compare how good etoposide and platinum is. And as you can see here, the mean and median progression-free survival for 4 of these combinations, as you can see, are not too different. In fact, for etoposide platinum, it is 9.35. And for pemetrexed, it is 10.76. And this was the most expensive regime at that time because we didn't have generics. And if you look at the survival again, you can see that etoposide with cisplatinum is doing pretty well. So we actually suggested that this was a regime that is being underutilized and we need to use this better, especially for our region because this is very economical and cost effective. This is the other paper which was published by Dr. Purvish and our group in 1996. This was looking at low dose prolonged infusion of gemcitabine. And again, this was done when gemcitabine was very expensive. We didn't have generics. And the basis was that enzyme saturation occurs at infusion of 30 minutes. And enhanced antineoplastic activity can be increased by prolonging infusion time. And we showed that we could decrease the dose by 33% when we gave it as 350 milligrams per meter square over 4 hours. And this was a pilot study of 30 patients. And the response rates were 68%. And this is one of the best reported in the world. And we showed that the cost reduction was a huge 66%. Of course, today we have a lot of generics, gemcitabine, so it may not be too relevant today. But again, just because a drug is not expensive doesn't mean we can not afford to actually save some of the drug for using it to the others. Now we heard a lot about tumor markers, and this is just to show you how patient selection has improved treatment in non-small cell lung cancer. And today we are talking about molecular selection and that the survival has dramatically improved. So I will just show you one example of how we have used TKIs better. And this is a slide, I'm sure you saw it earlier in Dr. Bhattacharya's talk, that we have evolved in EGFR mutation understanding and the development of drugs from the initial first generation. Today we have the third generation drugs, but all these drugs come at a cost. And therefore, this was one of the papers again from India looking at combining gefitinib versus gefitinib plus pemetrexed and carboplatin. And this is from Kumar Prabhar's group at Tata Hospital. And they actually showed that the median progression-free survival for the chemo plus gefitinib was 16 months versus 8 months for gefitinib. And for the median overall survival, it was not reached for the chemotherapy combination arm. So I think this is again a wonderful way of trying to use the drugs best in a low and medial economic country. The other evidence that we have looking at EGFR blockage is using the monoclonal antibody. And for the West, we have data from cetuximab. For India, we have this monoclonal antibody called nimetuzumab. And we have one of our first papers that we published showing that combining nimetuzumab with the chemotherapy increased the response rates to 60% from a 40% for the chemotherapy arm. And we have subsequently published this in 2014. So again, this is if you really need to use a EGFR blocker in a monoclonal antibody, we have a more cost-effective way of doing it by using nimetuzumab. Now, this is another exciting paper that we just published, and this is looking at combining minocycline with gefitinib. And the basis is that people were using minocycline to decrease the rashes that came out with TKIs, and ultimately they realized that this combination was somehow improving the outcome in these patients. And then they realized that was because minocycline inhibited the PARP1 pathway, and the EGFR mutant tumors are deficient in the BRCA gene, leading to synthetic lethality. So this was one of our first papers that we have published, and this is to show that for the survival, gefitinib arm we have a median progression-free survival of 9 months, whereas for the minocycline and geftinib, we have not yet reached. So I think this is again a very cost-effective way that we can target these using this combination. So let me come on to the next one, breast. We know that hormone therapy is very, very important for breast cancer, and this is just to show you the hormonal pathway, how it affects breast cancer. And this is again to show you how we have evolved in the targeting these hormone receptor pathways with various drugs. But we do understand that with sequential use of these hormones, there's an incremental decrement of response, and ultimately there is resistance. And we have now understood the various resistance mechanisms for this. And one of the mechanisms for resistance to letrozole was being targeted by this drug called everolimus, which targets the mTOR pathway. And this was the Bolero-2 study, which was showing you that this concept is in fact possible. And this showed a clinical benefit rate of 33.4% for the combination versus 18% for the letrozole arm alone. So you must be wondering why I'm showing you the Bolero data. It's because our group headed by Dr. G S Bhattacharyya, at the same time when this Bolero study was presented, he presented this data on reversal of tamoxifen resistance by addition of sirolimus. And sirolimus has been there in India for a very long time because the nephrology people have been using it for their transplant program. And we know that it's pretty safe and it's economical. So what this study actually showed is, I will just show you the clinical benefit rate was 62.1% for the combination versus 14.4% for the single arm of tamoxifen. And if you remember the Bolero-2 data, this is much, much better than that. So I think this is another way of cost effectively trying to tackle hormone resistance in our patients. So this is another paper that Dr. G S Bhattacharyya actually presented. This is looking at low dose temozolomide with a compound that he has actually patented, VT122. And this was presented in ASCO in brain tumors. And why I'm showing you this is, this particular combination has gotten orphan drug designation from the FDA. And this combination is propranolol and etodolac for the treatment of malignant gliomas. So this is not a very expensive combination, and it is possible that even in countries like us, we can effectively bring out combinations that can be approved by FDA as well. So the other thing I thought was I will share some experiences as to how we are trying to, again, look at oncologic emergencies. And one of the important ones we look at is tumor lysis syndrome and neutropenic fever. So in especially tumors like non-Hodgkin's lymphoma, where the doubling time is rapid and they have spontaneous tumor lysis syndrome or chemotherapy-induced tumor lysis syndrome and febrile neutropenias, we initiated this pre-phase in non-Hodgkin's lymphoma, and this we have published in European Journal of Hematology. This is essentially using 2 weekly doses of vincristine and steroids before we actually start the intensive chemotherapy regime. And from this, we showed that by using pre-phase, we were able to improve the performance status of these patients. And as you can see, some of these were performance status 3, and we really eliminated that after 2 weeks of pre-phase. And not just that, we were able to decrease the incidence of grade 3 and 4 neutropenia and febrile neutropenia as well. So I think this is another simple way of trying to avoid oncologic emergencies in our patients. Again, metronomic chemotherapy, you've heard a lot, so I don't think I need to go into the basis of this. So this is what metronomic chemotherapy is and how it is different from conventional chemotherapy. And again, this is from Dr. Kumar Prabhash's group, which is published in the South Asian Journal. And they concluded that addition of erlotinib to this metronomic chemotherapy schedule of methotrexate and celecoxib resulted in promising PFS, and this should be tested in future studies. So again, this is a very cost-effective way of trying to treat our patients. And especially in the pandemic situation, this was a paper that was published from AIMS. They were looking at metronomic chemotherapy for head and neck cancers, and they showed that this was again important, especially in the pandemic times when these patients may not be able to reach to get systemic chemotherapy. So like I mentioned, generic drugs, including chemotherapeutics, biosimilars. For the biosimilars, we have rituximab, GCSF, EPO, and a lot of other supportive care as well. And of course, increasing the medical personnel. So this was one of the first papers that was published looking at rituximab, the originator, versus Reditex, which is made in India. And the conclusion from this study was Reditex is as efficacious as MabThera in terms of response rates, progression-free survival, and overall survival with comparable toxicity. And this is at 5-year follow-up. So our biosimilars are just as good. And this was one of the first biosimilars. Today we have several others being produced in India and marketed and approved by the US FDA as well. So an important issue that we need to tackle when we give chemotherapy is nausea and vomiting. For this, one of the most recent drugs was aprepitant, which when it came was very expensive. So we did the study to compare the cost effectiveness and safety of olanzapine versus aprepitant. And I must really thank these 3 people who were marked in green, because they joined as DM students and all of them are consultants today. And we got an ICON grant for doing this study. And the conclusion from this pilot study was there were no significant difference between aprepitant and olanzapine in preventing nausea and emesis with highly emetogenic chemotherapy, apart from some drowsiness with olanzapine. So we do believe that this again is a very cost-effective way of taking care of nausea and vomiting. In fact, to tell you, the nausea was much better controlled in the olanzapine arm. Now coming to head and neck cancers, this again is an important issue in this region, and chemoradiotherapy has always been an important part here. But sufficient survival benefit is not there, and therefore we've been looking at using targeted therapies. And in 2006, 2 of these agents, cetuximab and nimetuzumab, were approved for use in this setting. And we have this data again from nimetuzumab in this head and neck cancer patients with a 5-year follow-up published in Oral Oncology. Again, as compared to cetuximab, this is a much cheaper version. And this has the advantage that you can combine it with chemotherapy and radiotherapy, unlike cetuximab. We already spoke about having guidelines. So, one of the things is the National Cancer Grid is making guidelines. The other one is the Indian Council for Medical Research has already published guidelines for about 24 tumor types. And the important thing here is they have 3-tier system for the ideal things that you should do, the next one, and the basic minimum. So we could use these guidelines and adopt this for our SAARC Federation again. Again, to tell you, this is one of our recent publications in Indian Journal of Cancer. There's a whole issue on Indian clinical guidelines for head and neck cancers. So this is a very comprehensive one. So if anybody is interested, you can go through this. So again, this can be adopted to the SAARC region as well. So this is what we are doing, trying towards the guidelines formation. So this is a paper that we published some time back, looking at treatment patterns and comparative analysis of non-intensive regimes in adult acute myeloid leukemias, a real-world experience. And again, this we published in Annals of Hematology. And you must be wondering why I'm showing you this. We did the study to actually see if we can use azacitidine initially. And just to tell you that the American Cancer Society of Hematology in 2020 guidelines have have actually cited our paper to for their guidelines in acute myeloid leukemia in older patients. So I think it's a proud thing for us that our paper is cited by these guidelines. So it's not just that we look at history and not just think on that. We need to actually move forward and try and see if we can do some cutting edge work as well. So I will just show you some things that we have done here. This is one of our papers published looking at testing anti-cancer drugs in ex vivo platform that captures tumor heterogeneity, and this was published in Nature Communication. Of course, this was a combined effort of several hospitals with some basic research laboratories. And we were able to show that using these platforms, we can actually predict the responses to various drugs. These are some examples from colorectal, GI cancers, and this is just showing you how each one of these pathways could be looked at. And in fact, they were better than many of these pathways that were detected. Again, this is for breast cancer and ovarian cancer as well. So we heard a little bit of discussion about liquid biopsy. So again, this is a thing that is going to come in. And this is some of the work that we have done looking at circulating tumor cells. And we did it in 2 cohorts of metastatic breast and colon cancer, breast cancer. And again, this was a collaborative work between Kidwai Hospital and 2 basic research institutions, the Indian Institute of Science and the Center for Bioinformatics in Bangalore. And we were able to clearly show that the culturing of these circulating tumor cells had a good correlation with the responses as shown in these graphs. This is for breast cancer and this is for lung cancer when we use Geftinib as well. I don't have enough time to take you through the details on this, but I will show you the publication, and if you're interested, you can actually go through this. And this again is showing you survival curves that we could correlate with the cluster formation of these circulating tumor cells. And again, we published this in 2019 in the scientific reports. So if you're interested, you can go through this and get more details. So the other thing that we were looking at is looking at circulating tumor DNA. And again, this was discussed some time back as to whether we could use this for diagnosis. And again, this is our paper from the circulating tumor DNA, the next generation sequencing. This was in our cohort of squamous cell carcinomas. And we did this in about 60 patients, 45 were adeno and 15 were squamous. And in this squamous cell carcinomas, 4 of them did show EGFR mutation. And in them, we were not able to get tissue because they had an FNAC and come with a diagnosis. They were too sick for a tissue biopsy. So we did the circulating tumor DNA. And as I said, 4 of them showed EGFR mutation. 2 of them actually were started on tyrosine kinase inhibitors and they did show response. So I think this is also possible in resource limited countries. I'm just showing you that we can do this as well. But the most important thing is collaboration. And like I said, real world data is very important. And as this person, Dr. Frederick Green said, the large scale sample size of data and the range of hospital types make the information contained in Ford's manual a viable alternative to institutional or clinical trial data as source information for answering some research questions. So that's the importance of real world data. And we are thankful to this person, Dr. Ramesh Nimagada, who is actually spearheading this, his foundation. And he has actually put up several hospitals on this OncoCollect software, which is shown here across all the states and various hospitals that have adopted. And he has made tremendous work in this area. And he has collected from 3 hospitals, as you can see, the number of primary cancers. And this actually shows you what is the incidence and the magnitude of various problems that are there. And what has actually come out is he's been able to show the time trends from 1996 to 2017 in over 51,681 patients. So this is real world data for you. I think this is something that can be done in the SAARC Federation, because this will actually tell us what our burden is and thereby plan what we can do for the future. And again, I have been able to try to get this study called Can Assist to validate in our SAARC countries. And we've just initiated, we have had discussion with all the stakeholders here. And I'm sure more and more people will come on board from the other countries. I think most of the people who came in for the first meeting were from Nepal and Bangladesh. I would really urge the people from the other countries to join in. And this is the study flow work. And this is important because this will help us to collaborate. And this is going to be a funded study. So all you need to put in is your effort. There's no money that is being spent from your side. And I'm sure that this will come out as a very important outcome, because we have data of this compared to Oncotype DX, which is very, very expensive. And just to show you, there is a concordance of 83% between these two platforms. So I think it is worthwhile that we all collaborate and take this study forward. Capacity building initiatives, we were just discussing that it is very, very important. And in this direction, we did a preceptor program for lung cancer. And this was in January. The second one was done in August. This was a virtual one. And I must thank Dr. Kamal, who is in this picture, for his initiative. And he also put forth a breast cancer education conference. Again, it was a virtual one. This we did in 13 to 15 November last year. So this is what we are trying to do in terms of capacity building in this region. And the other one I told you about is palliative care. Again, for this, Dr. Amit was spearheading this effort. And we did this impact training program for the SAARC countries, 8th to 9th Jan 2021. And this, I think, has been a good success, and we will continue to do this. And this actually was done in collaboration with the Ciclibs Palliative Care Foundation. So I must express my gratitude to them. So progress depends on collaboration, as I told you. Like this old African proverb goes, to go fast, go alone, but to go far, you have to go together. So I think I've tried to tell you in brief about what can be done, what we have done, and how what we have done in our country can be adopted to this region. With that, I will stop and thank you very much.
Thank you very much, Dr. Govind Babu, sir. A wonderful roundup of all the activities, your own institution, several institutions from India and the other SAARC countries, and this stress on that we may be economically not well off, but intellectually we are ingenious, and we can devise ways and means of overcoming our handicap. As they say, necessity is the mother of invention.
Absolutely.
We have shown to the SAARC nations that yes, you can be very inventive, you can be very innovative, and you can develop ingenious ideas indigenously for the SAARC group. Thank you very much for your presidential address. I hope everybody has enjoyed what he tried to convey to you, how well you can devise studies collaboratively between basic and clinical sciences, as well as between clinical sciences themselves. Thanks you once again for this opportunity.
Thank you.
For a wonderful keynote address as the president of the SAARC Federation of Oncologists.
Thank you very much. And thanks everybody, and good night, and we'll meet again tomorrow afternoon. Thank you.